Hello, good morning. Good morning.
Good morning,
Hello,
everyone.
hello, hello, good morning. Um, it's a Friday. It's a Friday, and we've come to our third day of the conference. And it's been a journey, to be honest. I don't know about you, but for me, it's been a great experience. We've learned, we've connected. Um, I don't know, it's been a lot of things that we've learned. And I want to tell you something that I've learned yesterday. Yesterday, I was reminded that if you take a journey alone, you're not going to get there. You can run as fast as you can, but this thing that we're doing, it requires a team. What did you learn? What did you get to do yesterday?
Mine was around the same thing. Just seeing how all the partners coming together, sharing the same goal and the same passion. And I think it really allowed us to have motivation and a clear vision as well of where we're going as RSOG and as a nation towards women's health.
Wow, that's deep. And I think we need to hear from you. What did you learn? How was your 2 days so far? What did they feel? Let's hear. Let's see if the people in the room, can you just give a microphone to anybody? Someone who is in front of you. Just anyone, please. I see, sure, Dr. Kane, one of our firstborns.
I think, thank you so much. I think this annual scientific meeting has shown us that we can do a lot, that we have great potential to even reach better heights. And it's just great to listen to all the great work that different stakeholders have been doing, and I'm only very proud to be part of it. So yeah, let's keep this up. I also want to learning all the different opportunities out there and interacting with different colleagues has also been one of my highlights as well. Thank you so much.
Great, Dr. Ken. I'm going to get output. He said we can do a lot. Output, output, output. Who else can tell us what they got yesterday? What transpired? What came to your mind? What did you learn? What did you get? Anyone? And yes, go ahead, Dr. Patel.
I was going to say something. So I'm one of the Canadian physicians, and I think I've been inspired by everyone working together with this common purpose. And sometimes it's a contrast to the Western style of medicine, where there's a lot more personal interest and individual motivation. Making money is a dominant conversation many times. So it's really nice to be here with all of you.
Great. That sounds like partnerships.
Yeah, I like that because passion was definitely shown here throughout these 2 days. And I think that's something we really love in RSOG ourselves. We really care for women, we care for children, and it's not only about the money.
Great.
Great.
Great. Anyone from this side? We've had people from the other side. Can you move the microphone around here? Let's hear, let's talk, let's engage. Let's engage. Thank you, Prof.
Thank you very much. The one thing that I learned is RSOG is getting involved in the residency education. That's, I think, very essential in standardizing training and probably mentorship, all these necessary inputs for a standard training. I think that has to be scaled up, and we need to come up with some exit exam protocols, things like that, and I was happy to see that. Thank you.
Thank you so much. I learned about quality yesterday. We spent a lot of time talking about quality, isn't it? Yeah, that's great. That's great. And thank you so much. Without taking much of your time, we're going to get another day of great experience. Yesterday and the day before has been a good experience, but now we are privileged to start our panel. But before we get to our panel, I've got some few housekeeping announcements. So today is our last day, which means we need to run through all the programs and make sure that we are done with the program. So my colleague and I are going to be lovingly reminding you about time with love. So either one is going to be seated here, if you can see, right here, which means we're going to be giving signs of time. We have a 5-minute and a 1-minute sign. So if we give you 5 minutes, it means like you have time to go through your key points and conclude. If we give you 1 minute, it's a very good reminder that you're probably trying to get out of time. So please, let's work on timing. 1. Number 2, we are reminding people that we have good exhibitors. These are the people who are here to tell us about whatever they're doing, but they have also supported the conference. So please, when you go out, go visit whatever they're doing. Number 3, remember to tweet and share the conference informations.
Just to reiterate, I just want to say thank you to everyone that came here this morning and has come on time. I think when you follow time, you're also respecting others who are going to present later. So I think it's a great way of honoring each other by following time. So that would be great today. I'm excited for the rest of the day. I'm excited with how it's going to go because these last 2 days have been amazing. So let's start with this panel and go ahead with the day. Thank you.
Great. So allow me now to welcome our first moderator for the first panel. She is a woman. We've been reminded, how much we need to have women at the front. She's a woman. And not just like a random woman. She's a gynecologist. Not just a gynecologist. She is a faculty member. And she is a tech savvy. She's a person who understands tech. And she's going to lead about new technologies in women's health. Put your hand together for Dr. Mireille.
Good morning, everyone. Yes. So I'm very happy to moderate this session because it is an interesting topic, which is about new technology and practices in women's health. So as we know, globally, technology has been incorporated in clinical practices and it is ever evolving. So it has significant impact on patients' outcomes and improving their quality of life. So this session is going to discuss about possible technologies available in obstetrics and gynecology practices in Rwanda. So without delaying, as we have been reminded that we have to follow our time correctly, let's welcoming our first panelist. So he's a professor in obstetrics and gynecology. He serves as a brigadier general at Rwanda. He serves as brigadier general in Rwanda forces, and he is currently commandant of Rwanda military and referral and teaching hospital. He's among founding member of Rwanda Society of Gynecologists and Obstetricians, and he has been working as president in the past. He has extensive experience in assisted reproductive therapy and minimally invasive surgery. He's a passionate educator, he's a researcher, and a mentor for all of us. So help me to welcome Professor Ngoga on the panel. Give him a round of applause when he's coming. The IT team can help us to display the bios for more details for the audience. Thank you, Prof. Ngoga. So the second panelist is an obstetrician, gynecologist, and surgeon. Also, he has a fellowship in Onco and in obstetrics and gynecological ultrasound. He's a director general of an NGO called AME. It's an NGO specializing in continuing training in African doctors. Currently, he's a general secretary of IRCAD Africa, a training center of minimally invasive surgery. And he's also working as senior advisor to Ministry of Health. So help me to welcome Dr. Charles Nsengiyumva to our panel. The third one, it's Dr. Barkachu. He's Nigatu. He's an associate professor of obstetrics and gynecology. Now he's working at King Faisal Hospital as a faculty position, and he's a fellowship program director of maternal-fetal medicine. He has a growing number of scientific publications in both national and international journals. So, Dr. Barkachu, please come on the panel. Give him a round of applause. So we have also Dr. Emmanuel Mutabazi. He's a clinical and radiation oncologist at Rwanda Military Referral and Teaching Hospital. He's heading the radiotherapy unit at Rwanda Military Referral and Teaching Hospital and Rwanda Cancer Center. Thank you, Dr. Emmanuel, to join our panel. So, as you are seeing, we have professors, doctors on our panel, and we are going to discuss about technology in our obstetrics and gynecology department. About those technology, there is the minimally invasive surgery. It is trending globally nowadays. Despite that, in our country, we are in limited resources settings, and there are unavailability of materials, but we are still doing those minimally invasive surgery. So my question is addressing to Dr. Nsengiyumva. How do you find the clinicians incorporating minimally invasive surgery in their routine clinical practices? Thank you.
Thank you very much for your question. In general, I would like to say that now, everywhere in the world, in advanced country, the minimally invasive surgery become routine, normal. And in many services of gynecologists, they practice 80% intervention by invasive surgery. And the question is, in Africa, in our country, how many interventions we practice by minimally invasive surgery? What brings minimally invasive surgery for us? We surgeons. I think many people here, you are gynecologists, you know that minimally invasive surgery is very interesting because the women don't stay at the hospital many days, only 3 days, 2 days for this intervention. Before, they stay 1 week, 10 days. The bleeding during the intervention is very low, no anemia. She can go back home very quickly. This has been proved that minimally invasive bring many positive situations for this woman. And you know that in Africa, women have a special place. Women, she go to work in the land. She must cook for the children. You know, when we make operation with the woman, who ask us how many days she will stay at the hospital. Because it's very important that you go back home very quickly. And we meet now many problems in Africa to introduce this new technology in our country. Why? First, the device is very expensive. The equipment is very expensive. Second, to train the surgeon that can practice this new technology very quickly. And you know, we say that our country are poor. I don't think we are poor, but we have problem to buy this new material, this new equipment. And here in Rwanda, I see we try to equip many hospitals, at the first university hospitals, and we try to put this new technology in second-level hospitals. For the training of the surgeon, I think you know the government of Rwanda makes many efforts to bring IRCAD Africa. IRCAD Africa is a center for training for surgeons in all specialty. We have IRCAD Africa in Masaka, and I think many of you will come to IRCAD Africa to learn, to be trained, to practice minimally invasive surgery. And I hope that in a few years in our country we can practice this new technology, who are practiced in other countries. If you go everywhere, they try to learn to teach their surgeon to practice this new technology, because it's very interesting to operate now with minimally invasive surgery, and not make laparotomy for grossesse extraouterine. I don't know if you have another question.
Thank you very much. You explained about minimally invasive surgery, especially in our routine practices as gynecologists. Hopefully, we are going to join those training programs as IRCAD have been involved to help us to be trained and to use those skills in our routine practices. And my second question is, how are you seeing the future of minimally invasive surgery in Rwanda? For example, when are we getting a robot in our first robot in Rwanda? Thank you.
Yes. we have a chance, a magnificent chance here in Rwanda, to have this center of training IRCAD Africa. And it was not simple to bring IRCAD Africa in Rwanda. It's very expensive to construct in a center like this. It's a big effort for our government to accept to bring a center like this in our country. Our gynecologists, we have our part to play too. When I see we have a course of gynecologists in minimally invasive surgery, and we don't have many students who come to this course. You know, I think we can organize 2 or 3 courses in a year for our surgeon. I know there's a problem. When they go back in their hospital, they can continue to practice this technique. But we are working on this. When you go back in your hospital, in Musanze or around, if you have the equipment, we can bring senior doctor who practice minimal invasive surgery and work with you. And I think in 2 years and 3 years, we can be very good in this technique in all over the country. You understand? And I think in few years, we work on it in the Ministry of Health, but I think our organization have his part to play too. And so in 2 to 3 years, we can practice this technique in our country, and it can be an example for the other country in Africa. They will come to look how we have done this to introduce this new technology. I say about what is very positive for the woman to be treated by this new technique. We must do it. We must do that. And I think we will do it in a few years. Because we have a center to train surgeons, we have seniors who practice this new technique. There is, well, our country, we have just the equipment, effort to the equipment, and when we have the equipment in our hospitals, I think we can progress very, very quickly, and the RSOG have a part to play, very important too, I think.
Yeah, thank you. Maybe
Thank you.
The Rwanda Society of Obstetrics and Gynecologists will help us to organize that so every gynecologist can get that opportunity to join IRCAD Africa so that we have those skills. Then when the materials will come in our hospital, we will have those skills and practice. Thank you. So we are going to Prof. Ngoga. As you know, Prof. Ngoga has been working for many years in reproductive therapy, assisted reproductive therapy, and I would like to ask him to take us through his local experience about assisted reproductive therapy and what is the nature of patient are you receiving there, and what modalities of therapy are we capable to offer here in Rwanda? Thank you.
So thank you very much for the question. Just maybe I think Dr. Charles forgot to say that at IRCAD we have one robot. So you can pass there one day and at least see it, put your head in and see how it works. So I think we are getting closer. Coming back to your questions, when you talk about productive endocrinology and fertility, it's wide. I'm going maybe to focus on in vitro fertilization. We all know that the first baby was born in 1978 in the UK, but it was hard work like 100 years back to get at that point. So it means today, what we are getting is a very advanced level of infertility treatment. Because in 1790s, when the first baby was born, things were done really in a very difficult condition. So meaning that you can stimulate the ovary. Actually, the first baby, it was a natural cycle, but the problem of the mother was the tubes. And then the scientists at that moment, they managed to retrieve the egg through laparoscopy. And I can imagine 1978, laparoscopy was not what we have today. It was quite also having some difficulties. But throughout the years, they developed a lot of techniques and improvement. So we no longer use laparoscopy to do egg retrieval, but now we are using transvaginal ultrasound with aspiration, which is much easier. Now we are not using any more stimulation with clomiphene, so we are using gonadotrophin. When they started, actually they didn't have to use what we call antagonists. So it means that you can stimulate the ovary, and at one point you can lose your eggs. So it means there's no control over the eggs how it is growing. But today we can control it, and we don't use the eggs. When they started again, they couldn't have the possibility of freezing the eggs or freezing the sperm. So it means whatever they had, they have to use them. So they used maybe to transfer so many embryos because they couldn't keep it. But today the facilities, the technology has developed that we can do what we call freezing of oocytes, of eggs, of embryos, and use them maybe in the future without spending a lot of money by injections. So with that also, another technology came in, which is called the PDG, pre-implantation diagnostic, genetic diagnostic, because people, they used to have so many embryos, they had time also to learn or to study how to get diagnosis of maybe genetic abnormalities, and this will improve the outcome. So what we have today in Rwanda is more or less the fruit of the efforts of these scientists, because today we have good technology, we have very good labs at a standard where everybody would like to get it. I think that time in the past where they started, people were even doing their own media, culture media. But today we have recognized companies with a standard who will bring these media. So in Rwanda, we have like 2 centers today. One is in private, another one is in government institution, which is at the Rwanda Military Hospital. So meaning that we are trying to make sure that this technology benefits a lot of people. We still know that this is very expensive because of the medication, the media, all of that. But the more we get involved, I think the price can go down, bring the insurance in so that they can pay and at least give some kind of smile to many families. So what we are going to do in the future here is to keep growing, to keep improving, to keep having latest technology, and also start training those who want to come in this field of infertility. And the more people will get, I think the more access will be to the people. Something I forgot to say, which made a big difference in this area of infertility, is the discovery of ICSI machine. And that was in 1992, if I remember correctly, in Belgium. This has helped what we call a male factor to be dealt with. It means that at one point, some men, they cannot produce sperm, but you can get it. And with ICSI, you can manage to get possibility of having a child. So a lot have been happening in this field, and a lot of centers around the world, and I think things are improving day to day. As I said, I'm focusing on IVF, but laparoscopy, it's very important also when you're managing infertility cases, especially correcting maybe some tubal factors, looking at the uterine cavity. So many things are combined together. And all these things are in Rwanda. So don't go and look for it somewhere else. They are just close to us here. The only thing we need for the young doctors is to get interested, to avoid, I can give a laparoscopy example. So the first thing which will make you maybe fear is, how am I getting in the abdomen? And everybody, the first trocar you insert in, you mean that you are perforate an organ. But try. 1, 2, 3, and the rest will come itself. So I think we are really improving in all those areas, and the opportunities there for the young generation. Thank you.
Thank you, Prof. Ngoga. So as what you are saying, a question came in my mind. I'm wondering, if the technology is evolving, there are some new technologies which are coming. They are about surrogacy, they are about sperm bank, are in our country. Are we able to offer those services like surrogacy, like having confidentiality or spam. If I want to get pregnant, I'm not married, I want some spam. Am I going to be able to get those spam bank? Thank you.
Yes, I think it's possible, and it's not difficult. Surrogacy is just to get a uterus for someone else to be involved in the process. And the law in Rwanda is not very clear about infertility. So it allows ART to be done, but they haven't gone into details. So when the law is not clear, so it gives you the room to do what you want to do. So we do surrogacy, but the problem with surrogacy in Rwanda is that when you give birth, the child is automatically yours. Because when I see you, you are the one who's giving birth. So the child is automatically your child. And the registration starts on the bed in the hospital today. So the only thing to do is, first of all, to get an agreement between the two families before even conceiving, so that we know when the baby is out, so this baby should go back to the biologic fathers. So I think that is feasible. Sperm bank, egg bank, embryo, those are things which are also possible because we have this possibility of freezing. And you can freeze so many years, 10, 15 years, there's no problem with that. And then that can be used to whoever wants to use them. So it's feasible here.
Okay, thank you. We are going to the third speaker, Dr. Barkachu Nigatu. So, Dr. Barkachu, you have been among first maternal-fetal medicine specialists in Rwanda, and you have been working in our local institutions like for 3 years now. So could you take us through your experience about the impact of maternal-fetal medicine subspecialty in our existing clinical practices and on our clients? Thank you.
Yeah. Thank you very much, Dr. Mirel. So before going to that question, I would like to appreciate what's being done at Rwanda Military Hospital with regard to reproductive endocrinology and infertility. And we receive a lot of pregnant women from them, so it's a very nice addition to the reproductive health sphere. And I should acknowledge that. And I would like to stress the point that we should only transfer 1 or 2 blastocysts or embryos rather than many. And that's being ethically done at Rwanda Military Hospital, and I think that should be appreciated. So coming to your point, the maternal fetal medicine program was initiated 2 years back, and we recently had 2 graduates from our fellowship program. The process actually started 3 years back. It took 1 year to approve the curriculum, and we accepted the first batch of fellows purely from Rwanda, and they have gone through a lot of internal and external training on maternal fetal medicine, and they successfully completed their training a couple of weeks back, and that was a huge success for us as a team. And I think it's also a huge milestone for Rwanda. As you all know, maternal fetal medicine utilizes technology quite a lot, and primarily ultrasound. Ultrasound is our main cornerstone of part of the training, and we use that technology hugely. And since we started the fellowship program, we have changed the kind of machines that we were using, and because that's very essential. As you know, the recent ultrasound machines have a lot of advantage in picking problems, not only for the fetus, but also for the mother. The few notable changes that we make since we started this fellowship program are, for instance, early first trimester screening. So as you all know, we can pick some major congenital defects between 11 to 14 weeks. And this is mainly possible by the use of technology, and that's ultrasound, with recent cutting-edge machines that we are having for the fellowship program. So we can easily pick those things and make a decision based on that. So that's one thing that we changed from the routine or the traditional practice. The addition of 3D, 4D ultrasound in our practice has also changed quite a lot. We can easily pick some clear defects that the mother is entitled to know before giving birth and make a decision based on that. The use of Doppler ultrasound also helps us quite tremendously in predicting complications or preventing major adverse outcomes. So that's another very important change since we started the fellowship program. And as you all know, we are now routinely screening for preeclampsia. Together with the biomedical tests, we use ultrasound to determine the uterine artery pulsatility index and integrate it to the biodata and also the biomolecular tests to predict the possibility of preeclampsia, by which we can institute an intervention and reduce the risk by up to 90%. So that's also something that we are routinely doing, and we are teaching all obstetrician gynecologists to go through that process. The other thing that we are routinely doing, and which was not there previously, is prediction of preterm labor and delivery. As you know, the main killer for neonates is prematurity. And how can we contribute in reducing perinatal mortality because of prematurity? We can do prediction using ultrasound and do interventions as early as possible and reduce the chance of preterm delivery. So those are the things that we changed since we started the fellowship program, and we want to scale this up. This training should not be limited to only a selected few. It has to go down to the residency program, it has to go down to the medical education. So I think ultrasound training should be incorporated into all the curricula for medical doctors, because you need ultrasound everywhere. Anesthesiologists are using ultrasound. Critical care people are using ultrasound. Endocrinologists are scanning the adrenal and the thyroid. Everyone, almost everyone needs it. So ultrasound training should start to be integrated into all the undergraduate curricula, and we as a team, maternal-fetal medicine unit, is eager to engage in training medical doctors. We already have a concept note to provide this training across the medical discipline, and if we get support from RSOG or other institutions, we can do that in a short period of time. What we need is standardizing the curricula that we can use for the different tier of medical doctors. Thank you very much.
Okay, thank you. As you said, it's good to incorporate that ultrasound courses in our curriculum for medical doctors, and also it's good to organize, maybe helped by Rwanda Society of Gynecologists and obstetrician and gynecologists, to go for maybe mentorship in our district hospitals to meet those GPs who are doing routine ultrasound, to show them at least some obvious malformations, fetal malformation, to detect those early, those malformations, and to give our patient a good quality of care. Thank you. For Dr. Mutabazi, he's a radiology, he's a clinical radiation at Rwanda Military and Referral and Teaching Hospital. As we know, radiotherapy is also one of the core treatment in gynecological cancers. But we know our patients are presented, most of them are presented at advanced stage. So how is radiotherapy contributing to cancer treatment in our population, gynecological cancers? Thank you.
Thank you very much, Dr. Mire. And I would like to thank RSOG at large for inviting me, because they are our partners, actually, the summary I can give. Another thing, before I approach to answer, I want to thank Rwandan government, especially His Excellency Paul Kagame, who inaugurated radiotherapy technology. It's a high sophisticated technology for sure that is doing great globally, not only for females, but also children men, human beings in general. So going back to the question you asked about we call them locally advanced, or in other words, inoperable cases that surgeons are not able to touch them. This is how we call them in radiation oncology. Again, my title as yours, some people don't know it because it's a new findings that is in Rwanda. So it's common for people to be not knowing who is a clinical oncologist, who is a medical oncologist, who is a radiation oncologist, who is this, because those are new things. But gynecologists are partners. We work hand in hand. I'm happy to see Professor Thaddeus here. He knows a lot of work. We work together. So this is very important finding. Another thing I can answer about it, to approach it was a summary. Radiotherapy is very important in, especially, I can give you examples. There are like 5 gynecological cancers I can mention. On top, especially here in Rwanda, we have what is called cervical cancer. Especially most of the squamous cell carcinomas, but we also find adenocarcinomas or few others. But the most common ones, when you read the guidelines, they say that the world or developed countries, Western countries especially, and the Far East like China, they have done great. And for that reason, they are reducing at a high rate the deaths caused by those cancers. So 80% of them, when you read guidelines, are in developing countries in which Rwanda is included. So for that reason, technologies that can help a big number of people to be treated is radiotherapy. So radiotherapy here in Rwanda especially is helping a lot for inoperable cervical cancers, number 1. Number 2, for vulvar cancers. Number 3, for vaginal cancers. And number 4, for endometrial cancers. And lastly, ovarian cancers when they are metastatic during palliation. For example, ovarian cancers, people think that we don't give radiotherapy. You will find those arguments. It's an ovarian cancer. We have to go with operation. We have to go with, please, we give radiotherapy in ovarian cancers, especially when they have bone metastasis, okay? When the patient is having spear pain, you see? So about those 5 cancers I can mention that any inoperable gynecological cancer, the next non-surgical local treatment is radiotherapy. So radiotherapy is given in 2 ways. We can give it in external beam radiation, or we can give it in brachytherapy. Here in Rwanda, as we are developing, we are not yet started radiotherapy, but the bunker is, brachytherapy, sorry, the bunker is already established. So which means we are on the track. I am happy to be with my boss. He knows more than me according to where we are going, and for sure it's a great job. But radiotherapy helps a lot to treat inoperable or adjuvantly or no. You see, he's he's telling me that it will come next month. You see? So we are improving a lot. But the sophisticated system we have here is called linear accelerator, using the machine is from a rector, and you have two machines using the energy of 6 MV, and it is using the technology which is very highly sophisticated one, which is called VMAT. VMAT rotates around the patient for 360 degrees. You see, its conformity is very high to the extent that you cannot miss a tumor unless to the someone who is not experienced maybe, and here in Rwanda we don't have those people. For sure, to tell you the truth, people working on those machines were trained in good countries with good expertise, so they just command the machine, and the machine, by the way, when you don't know what you are doing, it will not accept what you tell it. You see why VMAT Afande is very nice. VMAT, when you don't command it very well, you will see something red showing, no, we will not continue. So this is how I can summarize the greatness done with radiotherapy, generally globally, and here in Rwanda. I don't know if I answered your question.
Yes, you answered well my question. Thank you.
Thank you very much.
So, audience, please help me to thank our panelists to update us about our new technologies in our gyne obstetrics department. Give them a round of applause. So this is the time. If there is any question from you, the audience, you are welcome. Thank you. Someone to help?
Good morning, I'm Hani Fauzi, originally from Sudan, but based in the UK. A very interesting panel, and I enjoyed everything that you have said. It tells us that Rwanda is definitely leading the way, a long way in Africa. So well done for all the pieces of work that you're doing in your different specialties. I'm most impressed by the last presentation, and radiotherapy is one area that, in all fairness, is so expensive. My training in the UK had been on gynecology, and whenever I traveled to Africa, I was always asked, please help us to establish gynae cancer. The expense was one forbidding factor, but I'm so pleased that it started here in Rwanda. Well done. Two questions, perhaps a generic one, but maybe focus more about the minimal access. Why are you expecting so many people within Rwanda to start dabbling, and I would use the word quite conservatively, in minimal access? It should be a few selected people, but you seem to have that ambition that everyone, every resident should have an opportunity. Why is that so? But perhaps more, would you not feel this can be an opportunity for other African residents to utilize your center for this? And perhaps, generic another question is to bulk. Where does AI come into this modernization that you seem to have with scanning images and so on? Thank you very much.
Okay, thank you. Okay, one more question as we are running with time. Thank you.
My name is Maurice Buchago. I'm an obstetrician gynecologist working with WHO in Geneva. And I have a generic question. It's about the use of ultrasound. And we have a project here in Rwanda to support the scale-up of the antenatal care in health centers. It's an implementation research type of project. And we have also trained midwives and nurses in using ultrasound, especially for really, you know, getting the gestational age. A few things for to start with. But I know the vision was, from what you said, to train doctors. And the idea would be to say, can we also think about task shifting and, getting to the nurses and midwives, especially with AI. If we can add AI, I'm sure we can make it and, accelerate the progress. Just an idea based on the field experience. Thank you.
Okay. Thank you. You can comment about those suggestions and questions. Maybe we start with Dr. Mutabazi. From the comment from, sorry? He said about how to train residents, about that radiotherapy. It's a new thing, as you said, but are you planning to train more to get those new technology expanding in our country? Thank you.
Thank you very much. It's a very nice question. Of course, if you want to keep moving, you have to train. And you have other people that are studying, but they are still being trained abroad for radiation oncologists. Most of them, or clinical oncologists, most of them are being trained in other countries, either in Africa or in Europe. Especially we have like, I can remember like 4 people that are outside that are soon joining us, like all of us did, because as you know, as you mentioned, it's a very expensive thing. First of all, to train people, you need to have all the facilities or the professors in that career, or the books, or as you know, the libraries. So people are still being trained outside. Another thing I can mention about training people, we are also having another domain of oncologists that are not radiation oncologists being trained here. For example, nurses, medical oncologists, we have fellowships for them here. So we are doing great as a country. Thank you.
Thank you. Dr. Barkachu, any comment about what Dr. Boniface said?
Thank you very much for the 2 questions. They are somehow related, they are connected. So that is actually happening. And as you all know, since 2020, AI is being integrated into the ultrasound system, but it's only limited to some ultrasound machines, not all of the machines that we are having. But you can clearly see that the future is integration of AI into almost all ultrasound systems, and particularly point-of-care ultrasound. So that is coming up with handheld ultrasound machines that can be transported to anywhere, at home, at any clinic, health post, anywhere. So that's going to happen for sure, and definitely we'll need task shifting in those instances. If AI is integrated, there will be an automated analysis of the image, and it can streamline the reporting system. It will help also clinicians. So that is going to be the future. That's going to happen. We already saw some of these things with different machines, but it's not yet scaled up because it's still expensive. I think they also need more data with one sweep, identifying where the placenta is, identifying where the presenting part is in relation to the pelvis. These simple things can be done by anyone who is just trained to sweep across the uterus. So I think that's definitely the future. And I agree with you that we need to start thinking about task shifting and training more health workforce in relation.
Thank you for your nice session, and thank you for your kind attention for us. Thank you. You can get back to your seats.
Let's give them another round of applause. That was amazing. Thank you, Dr. Wineza. That was great. So just as a little break between our talks, we just wanted to present Judith Nyaboga. She'll be speaking from the company of Transfer Technologies Rwanda Ltd. as a GE distributor. We've been working with her and we just wanted to give her a chance to present herself. Let's give her a round of applause.
Good morning, everyone. So my name is Judith Nyaboga. I'm from GE Healthcare, but today I'll be presenting TTR Rwanda. I'm an ultrasound application specialist. I cover East Africa, and my background is in radiology. So today I'll just take you, we've been talking a lot about technology. Today I just want us to go through the technology that GE has invented that will make your work easier as you go about your day-to-day work at your clinical areas. Next slide, please. So I'll go through the GE ultrasound portfolio so that you get to understand. Have gone around the hospitals, and I really get a lot of questions about the GE ultrasound portfolio. So I'll go through the portfolio. So in GE, what they've done with the ultrasound systems, they looked at the care areas and they saw unique challenges that each care area had. So they set and segmented the ultrasound equipment according to care area. So besides being segmented according to care area, all the ultrasound can do everything. But the segment that we have here, like for the general imaging, they have unique features that will guide the radiologist to make their work easier, make diagnosis more accurate, and confidence during your diagnosis. So for example, for the general imaging ultrasound systems, which we call the logics, they are the systems that contain elastography. We know what elastography does, the contrast enhancement, and all the tools that make the interventional radiology easier. Then we have the women's health. So the women's health are meant for the OBGYN. They have unique features that we'll go through that will make your work easier, more accurate in terms of diagnosis, and we will see them all through. Then cardiovascular, these are systems that we really position in any echo lab because they have very unique features like strain for checking the heart, which you cannot get on these other portfolios. Then we have the point of care, and lastly the handheld, which is not here, but yes, we have a handheld which we use often in most of these projects whereby we teach point of care ultrasound. So those are just some of the systems that we have. And we have one that cuts across the portfolio. We call them the Vasana Premiers, and the Balance and the Active, which are portable. So now today we will speak more about the women's health ultrasound portfolio. I know we have a couple of them in some of the hospitals. We've done a lot with them. But today I just want to highlight for you the technology that is built in them that will make your work easier. So we start with the 3D. You realize from the system that we have out on the TTR stand, we have 3D, but you'll realize the 3D on the Voluson is totally much different from the 3D you will get on the Vasana Premier. So it has this element of HD Live, which we will look at it each one by one. What is HD Live and how it appears on the system. And what are the benefits of the HD Live? So the HD Live, it is a render. When you render, it brings that realness of the fetus face, and it will help you to see the realistic features of the fetus. You're able to also maneuver through the light source, which you are able to check around and check for any, for example, any facial anomalies that you might encounter, which you do not find on the other ultrasound portfolio. So we see the HD Live silhouette. The silhouette now helps you to see the translucency of the organ that you want to look at. And what does it help you in? It helps enhance diagnostic confidence, helps you make a confident volume assessment, especially in first trimester, as you can see from the images above. So the HD Live silhouette, again, as we spoke, it illuminates the fetal anatomy with up to 3 independent movable virtual light sources. Outside here, I think I showed some of you the one light source, which the HD Live Studio, you get it and you're able to see the 3 light sources, so you can never miss any from any illumination of any side of the fetus face or anatomy that you're looking at. So it helps you appreciate topography by use of 3 movable virtual light sources. It helps you enhance depth perception due to shadow effects, flexible light characteristics, light sources, brightness, and color. Then we go to the Sono Render Live. I think I've also demonstrated this outside. The Sono Render Live, it's similar to Sono Render. You start this feature, you enable it on 3D, you enable after you've rendered. What does it help you in? It helps you remove anything obscuring your, if it's a fetus face that you are rendering, and you're able to see your 3D well. What does it help you in? I think I mentioned it in layman. It helps you as you are acquiring 3D. It makes you, we all know that acquiring 3D images is quite cumbersome at times, but with the Sono Render Live, it helps you move with the sound in the liquid, so you don't really need to even look. It will move with the baby's, the region of interest that you're looking at. So automatically, you're able to get your fetus face or whichever organ that you're looking at without much struggle. So it assists less experienced users in rendering surface structures by looking for transition from solid tissue to fluid. So the HD Live Flow, it utilizes the first generation HD Live to present vascular structure with greater anatomical realization, as you can see on the image above. So the same. What is the Radiant Flow? As you can see from the pictures, in very few words, it helps you see the vascular feature, the vessels, like they will appear like 3D appearance, and so they make it look very nice. It adds height and depth information to provide a 3D appearance with less flash and enhanced vessel boundaries. So you will not, unlike color and sometimes PDI, you sometimes see the bleeding outside the vessel. With the Radiant Flow, it's clear, you see the borders nicely, and you're able to study your vascular structures. So we go for the Voluson Sono automation tool. I'll go through the years, how G has invented some of these features. We can go through them all. We can start with the Sono VCAD heart. I love the Sono VCAD heart. From one view of the heart, which is the 4-chamber, you are able to acquire a maximum of 8 views, meaning for any fetus, you can never ever miss any fetal anomaly. So this is beautiful, and all these are done post-processing, meaning you do the images, store to the system, and you're able to do the post-processing after the mother has left. You're able to go through each view one by one and analyze your images. Then what is the Sono AVC? This is especially important for the IVF centers. What does it do? We know that counting the follicles manually can be very cumbersome. So what it does, once you acquire your ovary, automatically the system will take, number for you the follicles, give you the volume, color codes for you from the largest to the smallest, and it gives you the volume. How beautiful is that? So it makes your work easier. You don't really, and in cases where you're looking at polycystic ovarian syndrome, this is going to be easier for you because you're able to know how many number of follicles are you seeing for your report. So this is a very good feature for IVF centers. Then the Sono NT and IT. This is the automated measurement for the nuchal translucency. Also, we know in first trimester how important that measurement is. Then the sonobiometry. These are automated measurements for all our biometrics measurements. And then Sono Render Live, we've looked at it. Sono fetal heart rate, it's just the automated fetal heart rate that we get. So this is how the Sono AVC looks like and how the follicles will look. It will number for you the importance there. It helps improve efficiency, workflow of follicular assessment. It decreases intra-user viability. It increases your productivity and patient throughout. And then excellent communication tool with the patient. The VCI is a volume contrast. It enhances your contrast. I think we've done outside even with the P8, whereby you're able to reconstruct your endometrium and you have your coronal view there. Then you introduce the contrast to make it more visual. So this is the OmniView. With the OmniView, you are able to reconstruct either your spine, your endometrium, and even your corpus callosum as well as you do your fetal analysis for the anomaly scans in the second trimester. So tomographic ultrasound imaging, also you're able, for example, you want certain number of thin slices of a certain part of the organ that you're looking at, and sometimes it's not so clear. You're able to activate the TUI, and you're able to actually select the number of slices that you want on the particular part of the fetus that you're looking at. It is actually similar to what we do on the MRI with the TUI. And it's available in all our portfolio. This is STIC. STIC is also for heart evaluation, where we are able to get 4D images of the heart and correlate both, and now this time introducing the color element. It helps facilitate recognition and confirmation or exclusion of congenital heart diseases. So it's a very good tool to have, especially if you're going especially in second trimester. Some of these features are going to be key for you in second trimester, where we are looking at fetal anomalies and you don't really want to miss any. You can make them as a routine because some of them, yes, come as optional, but they are really important. I have 1 minute. I think we've talked about fetal heart rate. I will not repeat. The central nervous system, again, from one view, you are able to reconstruct and get almost 4 views of the brain. We spoke about this. Maybe I speak about the beta view. Beta view, we know that TVS can be very uncomfortable to patients. When you are doing your procedure, immediately you go in longitudinal, you don't need to move the probe left or right side. With the beta view, you are just turning the one button. You turn to the right and you turn to the left. So you don't really need to keep turning the probe. But in this scenario, you will only be turning a button. So I think that's it, unless we have any questions for me. Thank you.
Thank you very much. We need to remind that they actually have a stand out there. So please, if you have some questions, work out, talk to them. They are happy to answer so many questions. And thank you for actually not just come to the conference, but also support the conference. As you know, for us to sit here involves something. We are running, trying to catch up with time, and I'd like to kind of shift the gear we're going to talk about leadership and ethics. And we've got, from the moderator and the panelists, the best people would have for this topic. So who is going to moderate this next session? Someone I've met for a long time, over 20 years of experience in education and training, mainly training the residents, senior consultant, a senior lecturer, a PhD, and a postgraduate coordinator at the University of Rwanda. He's in RMDC on the Professional Conduct Committee. His research interest is in maternal health, mainly in maternal near miss. He's a reviewer on a number of journals, and he's none rather than your favorite, Dr. Bagambe. Please, a round of applause to Dr. Bagambe Patrick.
Yes, good morning. Thank you, Dr. Magnifique. So my job this morning is to moderate two great speakers. The first one is going to talk about the essence of leadership. The second one is going to talk about ethics and medical practice in Rwanda. So the first speaker is Dr. Hani. As you well know, this is known accomplished leader in global public health and international development, especially in women's health and rights. With over 35 years of experience, Dr. Hani has significantly impacted women's health and maternal and newborn health through major roles in prestigious organizations like FIGO, as a director of projects at FIGO since 2019 to 2023, and he has also served as a vice president for global health at Royal College of Obstetricians since 2016 up to 2019. The list is long. I just picked few, and in his talk, I expect him to talk about leadership beyond authority. Through experience, our leaders have been using a lot of authority than teamwork. Welcome, Professor. Thank you.
Put my slides?
Yeah. Somebody put the slides.
Well, good morning, everybody. First of all, I would really like to express my genuine gratitude and thanks for the Rwanda. I was going to call you a royal society. You are indeed royal in every sense. But the Rwandan Society for Obstetrics and Gynecology for giving me the opportunity to be with you here. I've been to Rwanda several times, and I just feel at home. My presentation is really going to talk about the essence of leadership, and perhaps I had put a dash, but your system didn't accept the dash, cultivating humanity. Before I start giving you anything that perhaps gives you some aspects of what leadership is and its essence, I'd really like to ask you with a show of hands, who in the audience feel they are, so you as an individual, is a leader? Put your hand up, please. Okay, is that all? Keep your hand up, please. Fair? People might agree that it's people who talk to you being a leader rather than you see yourself a leader. But hopefully by the end of this presentation, we might ask the same question again and then see how different it is. Another question before I carry on. Who thinks that leadership is innate? That you are born to be a leader? That few people are born to be leaders, and once you are just born, you are either a leader in the future or you're not. Who thinks it's an innate talent? Put your hand up, please. Okay? Who thinks it's there's only one person putting their hand up? That's fair enough. I like that one. Who thinks it is something that you need to learn and there are skills? And it's like every subject that we do. I'm pleased that there are so many more hands going up. Okay. What I'm going to give you in this presentation, I promise you I'll keep to time, and I definitely hope it's going to be even shorter than my time. There's going to be nothing that is new in what I'm going to share with you. But I'm going to give you a caveat, and I would like you to think of this caveat all throughout. What I'm going to share with you is common sense. But common sense is not common practice. We all think it is. Yeah, nothing new. I'm not going to share anything that you feel like, wow. But perhaps the wow that I would like you to feel at the end of this presentation is that, wow, I'm already a leader. I don't need for other people to come and label me as a leader. Let us see how it goes. Okay. I had one, that's great. In this slide, I was just sharing with you the key concepts I'm going to go through. And I'm going to talk about organizations in general, perhaps what are the 4, what I call chronic problems that organizations face. And I'm not going to leave you with just the theory of why organizations fail. Well, hopefully, I'll share with you some solutions. And that will confine itself in what I call humanity and a whole person paradigm. We'll talk about that. We'll try and define what paradigm is. And then you hear this phrase, a paradigm shift is needed. What is the paradigm in the first place? I will emphasize the aspect of choice as being a habit that we should really be thinking of. And in all fairness, that leadership is something that we choose to be as individuals rather than what people tell us. And then share other elements that relate to engagement and a very fundamental principle about how we react, but we need to be more proactive in our approach to things. And when I talk about essence of leadership, I'm going to really use that whole person paradigm, and I will be talking about a mind, a body, a heart, and the spirit of each and every one of us, and I'll make some conclusions. Here is Samuel Smiles. I'm sure a name that not many people know about, but he's a Scottish guy. He's a medical doctor who got disillusioned with the medical profession. He is a bit ancient. He died in 1904. But in 1859, he wrote a very seminal book that is still taught in many leadership institutes about self-help. That's the title of the book. He's known for one particular thing, that the biggest important phrase that he used, or quote that people ascribe to him: heaven helps only those who help themselves. So you can see the focus is really on the person individually. And he's a reformer, acknowledged as such, and turned into writing and journalism. And in this particular quote, I'd like you to see that everything starts with a thought. It's in our mind. It starts with thinking, followed by some action. The action reaps a habit, a continuous habit. And I'm sure I don't need to remind you of any particular habits that we do them unconsciously. We don't think of them when we're doing them. Driving a car, it's a habit. Brushing your teeth is a habit. Once you get in the car, you just move. Once you hold the brush, you go on with your brushing your teeth. And that is where characters are really formed. And I'd really like you to have a link between the thought and the destiny. We need to begin with an end in mind. Everything has two creations. Every aspect. This microphone I'm holding in my hand, someone thought of it and then went into the process of whatever it is. This room, this screen, everything in the world starts with the idea, the first creation. And then it's what happens in actions that really takes us to the next steps. In level of effectiveness, you can see this concentric circle. And at the heart of it is us as individuals. But obviously, we work together in a team. If you want to think outside teams and work in a family, in the community, in the village. And that is what constitutes, perhaps, organizations. But what is effectiveness? People confuse the term sometimes with efficiency. Efficiency is effectiveness, thinking of resources. But effectiveness in itself, perhaps the best way that we can understand if we really want to be effective, we need to be doing something continuously to give us an outcome that we want, that is desired. And perhaps I'll tell you a story that you might have come across when we were at school, Aesop's and fairy tales. You like fables and fairy tales. I'm sure all of us do. The goose and the golden egg. You remember that story? Once upon a time, a farmer had chicken. And one day, to his surprise, he finds a golden egg. He takes the egg to the market. What a surprise. This costs more than the usual eggs. Happy, he goes back home. The following day, another egg, golden. He takes it to the market, gets excited. Wow, the third day, the fourth day. What's the rest of the story? He decides to do what? Let's kill the goose. And I'm going to find all these eggs, and I'm going to be rich. Rather than having to be patient and waiting every day for one egg, I'm going to have a full sack of eggs that will make me rich. And I'm sure the essence of the story here is about greed. But I'd like you to think of that story, the egg and the chicken. Which comes first? People would argue. It's a philosophical argument I don't intend to go through. But think of a product and the production capability. The product is your egg. The capability, the production capability is the chicken. Look after the goose, you'll get the eggs. Looking after ourselves as individuals, that's where it starts. Invest in yourself and all the ripple effect. Your team and your organization is just going to be second nature. Okay. I talked to you about 4 fundamental problems that every organization faces to a slight degree of difference, of emphasis. At the heart of it is an element of low trust. Other elements relate to no clear vision or purpose. Where do we want to go? What is our objective? What's the strategy? What's the operational abilities to the structures? Where's the money coming from? And I'll talk a bit more about this. The bureaucracy that exists in organizations, the misalignment of systems or lack of them. And the last one is that there are so much of workers in the organization who are not utilized for the talents that they can bring to the organization. So think of these 4 chronic problems, and in a nutshell, I'm going to share with you that perhaps the solutions are very simple. At the heart of these, inspiring trust. At the heart of this is the trust element. And you'll see how fundamental this is when we talk about the whole person paradigm. Clarifying the purpose sounds simple, but you'll be surprised how many organizations are not very clear about where they want to go, what is the purpose of them existing. Systems, we talked about them, aligning them, and I'll share some more about these systems, and then unleashing the talents that I have shared. And here, in a nutshell, is what I'm trying to go from now onwards, the roadmap for this leadership journey, so to speak. A mind, a body, a heart, and a spirit. And you can see the mind, clarifying purpose, the body, the systems that are put in place, the heart is the talents, the passions that people have in doing the work they want to do, and at the crux of it, the legacy, the spirit that organizations, but perhaps more individuals in the outset should really be thinking of. Okay. Another term we talked about is paradigm. And we talked about, everybody says a paradigm shift. We need a paradigm shift. We need to have a different way of thinking the way we see the world, the way we understand the world, the way we interpret the world is our mental map. Perception is reality. The way we see things is our way of the beginning of the process. You remember? So a thought, reap a destiny. It all starts there. That's what the paradigm is. You have glasses in front of you. Through them, you see the world. If you think of it, the world being great, you will do great things. If you start thinking that the world is not, your perception will definitely help you in building the next steps that follow, the action, if you remember in the quote. And perhaps this is a paradigm, or this is a vicious circle that you can see it in education. We do it. Do one, see one, do one, teach one is another great motto that we use in teaching and learning new skills. And it is the C element that is the thought. That's the beginning, that's the paradigm. Seeing things, interpreting things, understanding things through our mind. The action is the do, and the get is the result. I'd like you to think that perhaps if you don't like the results, what can you do? You try and modify the actions, the behaviors. And in changing some of our behaviors, we might improve on our results. I'm sure people quote that Einstein said, if you carry on doing the same thing and expect a different outcome, you must be insane. That's what the definition of insanity is. What I'd like to challenge you with, perhaps, if you don't like the results, if you don't like the outcomes, change the way you think about things, rather than just increase your effort in changing your behaviors. The way we see things really is the beginning of everything. Begin with the end in mind. And here is what paradigm shifts is all about. Okay, I talked about choices, and I'd like you perhaps to see where you stand from your organization. And here, the choice that you do, or going to work every day. Some of us might just feel, okay, I don't like this work, I'm going to quit, rebel. I don't like it. End of the story. Some people just maliciously go and are obedient as they go in, day out. Perhaps others are just complying willingly to keep the peace, not challenged in any way or shape. But let's look north of that line. The cooperation that you might be doing cheerfully. The commitment that is genuinely coming from your heart, a heartfelt commitment. Look at the uppermost creative excitement, want to build on. Beginning with an end in mind, you want to improve on what it is and help the culture, the organization, the environment to thrive. And any of these sort of situations, who decides on this is the individual. We don't think about it in that way, but that element of choice is really central to the whole exercise of leadership, as hopefully you'll see how things will unfold. We tend to be proactive, and when we're faced with a stimulus, we tend to give a response, and rightly so. It's human. Imagine yourself reaching at traffic lights. There's a car in front of you. It's showing red. You are the second car in the line. The first car does not move. You'll be surprised. Start waiting, nothing happens. Horning the guy in front of you, doesn't move. Okay. It turns green. Hey, nothing is happening. At red, you're not moving. You're a good man. At green, you're still static. What's happening? It turns red again. Hey, what's going on? What is the stimulus? Is that car just standing in front of you? Your response to it. There is a gap between the stimulus and the response. There's a small gap. The wider we can expand this gap, the moods, the feelings, and the circumstances are going to decide for. If you're going to make it so much short that you respond reactively, you're not going to be happy with yourself most of the time. And here is perhaps that element of choice very much exercising itself. The self-awareness, the imagination. How much beneficial is it for me to be? What's wrong with the person there? He might have a heart attack. He might, for whatever reason, cannot move. What has gone on? Why that person is not moving? What is the right thing and the wrong thing to do at that stage? The consciousness. And it's our independent will throughout this exercise. So in this gap, I'll challenge you, lies our happiness, lies our leadership potential. How much of a gap do we widen, and how proactive we are to really take all these endowments that are all human endowments. They're nothing, animals unfortunately don't have those sort of endowments to handle situations. Okay, so we talked about the mindset. I'm going to share with you the solutions. And we talked about the mind, the body, the heart, and the spirit. As long as people have a clear job description, they will be fine. That's a mindset that many leaders have. It goes into our system. Perhaps think of a better mindset. If there is a clear and a compelling vision that exists, people will volunteer their best efforts. You can see the first paradigm is a mediocre paradigm, and you would want to change it into a more effective mindset. So here is an element where we need to change at the mental, at our mind level. What is the purpose? The end in mind. What is the job to be done? The clarity that we need to establish. What is the strategic link? Whatever activities we're doing, how do they link to the strategy of the organization, of the team, of the family? And perhaps one aspect that unfortunately many of us in charities, like the RSOG, don't think of, a money-making model. And we're a charity, we're not for profit. What does that mean? You still have to have a money-making, the business acumen comes into this. So here is a mind, at the mind level, we have to have clarity of the purpose, the job to be done, the strategic links, and the model of making money. Let us see a different mindset. Everything is dependent on me. Benjamin had asked me to emphasize on that authority perspective. That's a mindset of many colleagues, leaders. Enduring success is in the systems. You remember in our aerial example when we talked about the mind, body, heart, and spirit and the chronic problems. And here is the solution that we talked about. Aligning systems. In every organization, at the family level, you have to have a system. I'll share with you one system, perhaps what we describe in this example of execution. To start with, you have to have a very clear discipline, focusing on 1, 2, or 3 clearly, wildly important goals. If you start thinking of 20, you're going to execute on none. The focus on things. Let us just, for an example, to help us go through this very briefly. I want to lose weight. Good goal? Act on lead measures. What's lead and lag measures? If I just want, in 6 months' time, I'm going to want to lose 10 pounds or 10 kilograms, and only 6 months, have I achieved it, have I not achieved it? It's a lagging measure. The lead measures would be, what is it that is going to make me lose weight? Simple. Eat less, exercise more. So if I want to act on eating less and exercising more, make some sense in a discipline that will help me reach my goal. The third element is you have to see, visualize your progress. Keep a compelling scoreboard. Many people will tell you that what cannot be measured cannot be managed. And you can think of it as simply here. If I don't have a way by which I'm seeing, monitoring, and evaluating where I'm going, how is it happening? And the last aspect is, if this is achieved, have this creating a cadence of accountability. having a friend who can keep reminding me, having a system by which I'm going to feel like, okay, if I achieve this target, what else comes into place? But that cadence, the rhythm of following up on myself. Let me move to the third aspect, the third element in our mindset. I need to constantly motivate my people to get results. Mediocre mindset of many leaders. Look at this. My job is to release the talent and passion of our team. How strong, how powerful is this? And here is where unleashing the talents come. Discover your voice. What is it that you want to do? What's your unique contribution in this world? What is it that you want to really leave behind? What is it that you want to be? Whatever it is, look at the need of the people that you're serving, understand their passions and why you are doing this thing, why do you like to do it, the talent, the conscious, and it is in this conglomeration of these 4 concentric circles that you define your voice and help others to find theirs accordingly, unleashing the talents. In many organizations, there are so many people who are not as much as passionate, but not being able to have the opportunity to exercise their passion and their talent. My last element of this mindset is our legacy. I get things done because I'm the boss, another form of authority, the formality of that authority. How do you feel about a different mindset? I get things done through personal influence and credibility, the informal, the moral authority. And in all fairness, here is another perhaps element I could go at length to try and describe this. Your character and the competence comes to this inspiring of trust that is really at the heart of being credible. And when you saw the concentric circles, it starts with the center as being the individual. Integrity is individual, but equally, integrity can be something that the organization, the culture, the environment does. So here it is, another very powerful thing. I hope I have shown you a mindset that was mediocre, and hopefully if we work on our changing that mindset, we can really have a better, more effective, whatever team and organization. I'm going to conclude with my last slides that really relate to just joining all these bits together, how we should be empowering our communities, the ones that we aspire to serve. And leadership is not about a title. Leadership is not a position. Leadership is not a status. It's not an office. It's not a rank. Leadership is a choice, and each and every one of us has to exercise that particular choice. I'd like to challenge you that perhaps ignite our humanity, empower our professionalism. Everything that I need is exactly what everybody else needs. Everything that I want is exactly what everybody else wants. How do I define my own needs and my own wants and help others when I find mine to define theirs? I want to ask my question at the very end of this, the same question I started with. With that sort of aspect, and perhaps sharing with you what I would call the essence or the imperatives or the crucial elements of leadership, thinking of our mind to learn and unlearn things, with our body that we live with our hearts where we unleash talents and love, and the spirit of it, of leaving a legacy. What do we want to be remembered with? Who thinks he's a leader? Can you put your hand up, please? With a show of hands, who feels that they are definitely leaders and the choice is within us as individuals before it starts rippling out? Show of hands, please. Who feels that they are a leader? Who would like to exercise that choice of leadership? Well, thank you very much. I appreciate your listening.
Thank you, Professor. This has been a very, very nice talk. The last slide, leadership is not about authority. So Bureaucracy, authority has been our way in Africa. It's high time we stopped and pick what's being experienced elsewhere. So our next speaker is Dr. Gasana. He's going to tell us about ethics and medical practice in Rwanda. I happen to have been working with him over the past 2 years. The Rwanda Medical and Dental Council, if I may say, the last like 20 years, it was hijacked by few people. Those who had hijacked it were authoritarian. For the last 2 years, we are seeing a change where doctors sit, where RIP doesn't come in, where the Professional Conduct Committee comes in first. And we deal with the litigation cases that are facing our doctors. I expect him to tell us more about that. So Gasana is the chair of Rwanda Medical Council for the last 2 years. He's the chair of National Transplant Organ Committee. He's a senior consultant urologist since 2012. Yeah, he also established a functional unit of urology at Rwanda Military Hospital. As we all know, for the last 20 years, those who face problems, litigation problems, obstetrics, gynecology, it stands at 90 and above %. So I expect him to tell us the malpractice issues we have in Rwanda today and the solutions that are in place. Welcome, Gasana.
Thank you, Dr. Patrick. Distinguished guests, colleagues, I'm honored to talk about ethics and considerations of ethic and constitutional rights in obstetric and gynecology. When I started to prepare this presentation, I asked myself, is it possible to live or to practice without malpractice, without litigations? I raise this question because on a daily basis we receive complaints as a regulator from various institutions because of unsatisfaction of patients. Therefore, I decide to highlight some aspects where we need to improve and try to achieve the best practice that we are aiming at. Probably at the end of this presentation, we may answer if we can live without malpractice. This slide shows how, gynecology and obstetrics is on the front line of, complaints. And I want to take this opportunity to apologize that I don't want to undermine the great job done by gynecologists. We know that the practice gynecologists, they deal with anxious patients, and sometimes they thought that they are between life and death. And remember, the ratio of doctors to pregnant women is low. We have around 125 gynecologists all over the country, and most of cases, most of women deliver into health centers and district hospitals, and we cannot have, so far we don't have enough gynecologists to cover the health centers and district hospitals. So this number is not 90 complaints. 90 complaints is about 100 complaints. And out of 100 complaints over the last 3 years, GYN is leading with 60 cases of litigations. And we remember that in district hospital, most of time, deliveries are done by either midwife or general practitioners. But again, they are mentored by gynecologists. So it is important to talk about it so that whenever you mentor them, just remember that we are aiming at reducing mortality rate and also aiming at patient satisfaction. I know that the concept of malpractice is known by everyone, and our objective is to explore whether malpractice in obstetric and gynecology can be avoided through strict adherence and ethical principle and constitutional considerations. When we conduct investigations of different litigation allegations, we find that most of the time the problem are not related to the skills, but rather than attitude. And therefore, we need to improve our attitude, the way we perceive things, the way we operate, the way we treat patients. And I remember the president of FIGO the day before, she was talking about taking care of patients holistically. We don't want doctors who want to become stars, but we want doctors who are there just to solve problems, interact with colleagues, seek for consultation, for advice from colleagues, but also, consider the patient as holistic rather than being a private patient. Those are principles that guide any health professional. We need to, to consider the autonomy of the patient and get the consent from the patient, but also we need to consider other principles like beneficence, non-malfeasance, and justice. In order to achieve, to observe these principles, there are skills that a health professional must have. The health professional must have soft skills that enable him to, to respect or to follow these principles. And actually they are the core medical ethics, and if we are able to follow them, then we can meet some of the expectations from the patient. The patient, a pregnant woman seeking for treatment to the medical doctor is expecting a lot from him. Therefore, we need to engage also the patient. We need to interact with the patient in order to get trust from her so that we can have a balanced treatment because as a dilemma, we need to balance patient autonomy versus medical judgment and also a consent in high-risk procedures. There are few doctors who are not engaging colleagues or discussing with colleagues about the management of the patient in order to optimize the outcome. And this is very critical because we, as I said, we don't want stars. We want solve people who are there to solve the problems and assist the patient to the extent the patient can get satisfaction. Of course, most of the time we think about patient satisfaction, but we forget healthcare provider satisfaction. That is another dilemma that we have to emphasize on. An institutional ethics, this is another concept that must be emphasized on. As the previous speaker said, the leaders, they tend to become authoritarian rather than being problem solvers, or there is no such direct, interpersonal relation with people to try to solve the problem. But also the doctors should start to think about engaging the leadership in the problems that they are facing on a daily basis. Of recent, I met a colleague who was struggling to find a slot in order to operate, and was delaying without solution. But he didn't tell to his leadership that there is no slot, but the patient is in critical condition, yet it is happening in a hospital in Kigali while he can seek, help from another hospital where we have the same specialties. So we need to collaborate, we need to inform, we need to document. But what we have observed is that we lack those skills of communication, those skills of, documentation. So it is very important for the institution to establish clear ethical guidelines. They are there. Most of hospitals are having this accreditation, and whenever you visit a hospital, a district hospital, you find the guidelines on the door of administration. But how are they applied in order to, to emphasize on these values of ethics? But also, we need a continuous medical education in ethics in order to, to remind ourselves what we should do and how we should do it in a professional manner. And also we have to create a system of reporting and learning medical errors. In fact, incident, we have a culture of hiding incidents. And this is a bad attitude because incident reports help for improvement. Actually, somebody who is hiding incident should be punished because he's promoting bad practice. But incident, again, is not there. Some of our colleagues, they have a misconcept that incident, when there is an incident or when we report an incident, the person who did that mistake can be punished. That is not right. You can report, and we can serve that. Incident report to improve our way of practicing, of doing things. And sometimes within the department, you can, have a discussion on that, on what happened, so that we prevent the recurrence of the event. So there must be a kind of a systematic follow-up of ethical considerations and also medical errors that are happening in order to improve. And also an institutional policy must be put in place. They are available, and we must try to put some mechanism that can follow or monitor the mistakes that are happening. So, as I said, most of common cause of malpractice are related to lack of consent, informed consent, failure to diagnose medical conditions, or error during surgery, but they're minimum. Now, informed consent is not about the paper. It's about the documentation, but also the education. Sometimes you fill the consent form and you give the patient to sign, and later on, when there is a problem, you said, no, I didn't understand well. We need to take time and explain to the patient what is happening. Most of the time they come in, they have stress and they have much expectation from us, but also they need, a mental support. And when they sign, you have to explain in detail potential complications and how you can avoid some of the, or how can prevent some of the preventable complications. And that must be done through good communication, through clear, communication with the patient. So it's not about the form, it's about the way you interact with the patient to the extent the patient can, understand and sign what is understanding for. So we need to adhere to this ethical standard in order to reduce malpractice, and proper documentation is needed in order to fulfill our task in a professional manner. So soft skills. Why do we need those soft skills? We need the soft skills in order to solve problems. And soft skills are personal attributes that enhance an individual. Individual's interaction and also job performance and career prospect. UNESCO defined the skills that human must achieve in 21st century, such as the critical thinking, collective decision-making, lifelong learning, communication skills, and collaboration, teamwork, information management, and social responsibility. These are known as soft skills. Actually, this definition of, is more comprehensive. It has all aspects of soft skills. You cannot learn soft skills in a single day. It is a journey, a long life learning. But let us start in undergraduate, in teaching the, few principles of soft skills, introduction to soft skills, but also when the student, get exposed to patient, they will understand the need of those soft skills. Imagine a patient, just an example. I remember during our investigations, a patient reported that the doctor who was going to do C-section said, hey, by the way, I'm not in the mood. And saying that we are not in the mood in front of patient, and yet later on has complications, and she will attribute those statements to negligence. There are things that we should avoid loose talk. Whenever we interact with the patient, we need to have good attitude, good collaboration, and we need to control our statement. Sometimes, when they come for follow-up, I'm still on communication. You find that a colleague undermined his colleague, said, oh, yarakurangij, he finished you. Those are things that, and they will come back to counsel saying that, oh, I was told that my so-and-so is the one who did wrong practice, and now the complications I have, they are because he didn't take care of me. So we need to collaborate, we need a teamwork, we need to document, but also we need to eager to learn, because now medicine is evolving. We are talking about artificial intelligence this morning. We are talking about laparoscopic, minimally invasive, and now we have also challenged how to regulate artificial intelligence. I was impressed by Dr. Buchagu when he was talking about some projects going on at IRCAD, and then as a regulator, we need to come in and see how we can regulate artificial intelligence or equipment, I mean tools that are equipped with artificial intelligence. So we need to be conscious. So in order to, coming back to soft skills, we are living in a society with colleagues, so we need to have working skills, to respect each other and avoid statements that can affect our interrelations. We are human. We need to respect our colleagues, from the cleaner to most of seniors in the environment that we. And when we respect all this, we respect the patient, we talk to the patient in a polite manner, we interact, we engage our colleague, teamwork, we collaborate, then we improve our practice, and that is how we can, maintain our profession. So we need cognitive skills to, in order to achieve what I was saying, we need a critical thinking, the ability of apprehend and learn new things. So we need clinical reasoning. We need to learn how to document, how to interact with people, and that is the language and writing skills. And also we need complex and systemic skills. Why do we need systemic skills? Is because we need to have evidence-based information in order to get argument when we are discussing with the patient. And also we need to take into consideration cultural sensitivity. And those interpersonal skills we have highlighted are also very important. So we can spend more time discussing about those soft skills, but I think it's a task that we are given, so that we go back and read about soft skills and try to exercise them in our daily practice, and you find that they are useful, and you enjoy your practice if you respect, if you follow this, soft skills. But also, as senior people, we need to help our junior, our student, to grow in that line, and try to engage them in soft skills acquisition, to mentor them towards their profession, and also it become a cycle. So there are challenges in facing these people. They think that the way they perceive the soft skills, that paradigm, is like a secondary course that is maybe not needed, and that is kind of resistant to change, but also it is difficult to measure soft skills and their efficiency. But educators need to, to train and teach soft skills effectively. And this can be done through, continuous education, utilizing resources that are available, or also incorporate soft skill training in medical education. So, can we practice without malpractice? If you follow these values, you consider the patient as a holistic patient, you you embrace those values, you talk to the communication, to the patient, you take time to explain the patient about his condition, because every pregnant has its own reality because of various, aspects. So you need to educate, to talk to the patient, and also engage colleagues when necessary, so that you don't carry the burden yourself. And this must be done for the benefit of the patient. And whatever we do, whenever you meet a patient, try to give best care, best service, aiming at patient satisfaction. But also, I see, at least I can recognize a DG of one of the hospitals. I wish someday we can have many DGs around to hear about the healthcare provider satisfaction. Having 125 gynecologists in this country, the ratio of gynecologists to pregnant women is small, and we really appreciate the kind of service you are doing, but also you need to work in an environment that is suitable so that you don't have burnout or whatever. And again, we have realized that now these days, students don't want to join gyne and obstetrics because they are saying that, no, that is a profession with high risk. We need to talk to them. We need to encourage them, tell them that it is high-risk profession when you don't follow the principles and when you don't follow the values that govern our profession. So, colleagues, I think we can live without malpractice. I believe that. And let us reduce the complaints through these principles of ethic and acquisition of, soft skills that will enable us to practice in professional manner. Thank you very much.
Thank you, Dr. Gasana. May I ask you, before you sit, your previous seat, to go to the other side, please. You can shift to the other side with Dr. Hani. Yeah, meanwhile they are going, as you can see, throughout his presentation, there's one thing they always jump. All our leaders, from the ministry to the grassroots. One of the causes of malpractice is the system itself. The workload, the working conditions, the motivation. Maybe he might start with that one. You didn't talk about the system itself being a cause of malpractice. Would you please enlighten us some more? So this is a time of session for questions. Limit them to be short and answers. Thank you. So we only have 5 minutes for this. You have to limit. One question.
I can ask it?
Yes, go ahead.
Yes, I have a question to our chairman for Rwanda Medical Council. You said that we can live without malpractice. That's true. And you advised that we should collaborate. That's true. But to collaborate again, that's not easy. It's not easy. That's the truth. Huh? Now I want to ask my question. The limit, you know I am an obstetrician. The limit between malpractice and complication of obstetrics, it is not clear sometimes. The limit between malpractice and complication of obstetrics. When I am in a labor ward, you know very well that PPH can happen. When PPH happens, everything can happen. even if you manage it as you have been taught, you know that you can even end up by hysterectomy. And when everything are good, you have saved the mother, she's stabilized, then she'll come back to see you. Why did you move my uterus? You see, there again we are at the limit of malpractice. Because if she comes at Rwanda Medical Council, you will investigate, of course. So the limit between malpractice and complication, obstetrical complication, like PPH, so things
Enough.
like that, we need really to be clarified. Thank you.
So one more question and we are done. Yes, here.
Thank you. I'm Fulgence. I work in a district hospital, the newest in the country. My question goes to the chairperson of Rwanda Medical Council, Dr. Gasana. I appreciate the presentation, particularly on the side of soft skills. We know it can really reduce the way people communicate. But when we see our program in academic institutions, this part is not probably well developed. We meet in the working institutions, we start to care about it. So my question or my suggestion, is it possible to start early during education, probably design programs? It may be subjective how you can test soft skills, but I think it can be possible. So train people. I base my suggestion on previous practice when 10 years ago, one doctor, we were in the ward, has rushed to a nurse. A nurse was right on medication, but doctor respond, we didn't study together. So it was fun, it was a kind of self-defense, but he was wrong. And to manage that situation, it was really very hard. So my question is, or suggestion, is it possible to start earlier in education, design those programs, make exercise when people can really learn soft skills? Thank you.
Maybe I can complete my colleagues, but let me start by my friend, Hani, who have been together for so many years, I think from around 2012, and then Vancouver, and then Brazil, and then all around. I was surprised today to see you giving a lecture, actually. Thank you very much. I'm not asking you a question, but I would like to tell you that in the transformations we are undergoing in Kigali, in Rwanda, I'm so much happy to tell you that actually in the curriculum we are developing, or we have already developed, we have included leadership skills as well. So I believe that leadership is not innate, really. We can still pass me the word, we can still make them. It's not a question, and thank you for a very good presentation. And actually, I would like to have your copy. Coming back to my chairman there, thank you very much for your awakening call. The difference between incident and malpractice is blurred. It's completely blurred. Incident becomes malpractice when there is a sense of prejudice. And now that our society has become too much demanding, I think that we need not only to talk about this, but to have to sit down as a society and see how we can bear this burden, all of us. Institutions, legal societies, and many other people, so that we know exactly who has to bear what. Allow me to tell you, my dear chairman, that obstetrics is emergency forever. Even when everything is normal, it can still be an emergency. And another thing is, it's quite interesting, the obstetrics doesn't have shock absorbers like a car when you get into a ditch. It's not like internal medicine. When somebody comes in sick, and then you expect him or her to die. When in obstetrics you come to enjoy the event, and you come through the mortuary, it's a disaster. It's a massive social event. So I think I'm not asking you a question. Let's find a way of sitting together, bringing in insurances, bringing in many other aspects of the society to see how we can improve. Otherwise, it is very much difficult to handle. Thank you very much.
Let them answer those questions where time bad. So enough of the questions.
Thank you, Dr. Patrick. And let me start from your question. And I know you have been, advocating for, doctors, and I really appreciate. But system as cause of malpractice, to some extent, not in general, but we health professional, we have a disease of keeping quiet when things are wrong. And we are not there to praise our DGs or our leaders, but we need to talk to them and, engage them in solving problems. Now, why I'm saying that doctors are part of the problem rather than leaders is because when they see something wrong, they keep quiet and they stay complaining among themselves, but they don't have such courage. Few of them may have the courage to go and face the leadership. You are on duty, and you have, you receive 9 pregnancies, and you have only 2 midwives monitoring the labor, and you want to perform cesarean section at night in the district hospital, and you don't call even for help. Who has the problem? Is yourself, because you don't want to, to be proactive and prevent some of the problems that might occur. And again, the leadership, sometimes they don't want to sit and find solutions together with doctors, because if you engage people in a discussion showing the limitation, the challenge that we have, they might have less complaint. But if they don't engage doctors, for sure, people keep complaining. And when it becomes a chronic problem, doctors try to find solution themselves by deserting, getting out of the profession, and that is what we are facing. That is what we are seeing, because nothing maybe is done, or there is no improvement on that perspective. I think we need to call upon both leaders and health professionals to collaborate and sit. But again, let us talk, engage our leadership, our leaders in discussion that lead to, better improvement. And when you hide, or when you keep quiet, then, like the example I was saying, if you don't tell to the DG that you are having C-section at night, when the problem occurs, you will be sued. They will not call, they will not call the DG because you didn't seek for help. We have a clinical director. So please improve the communication, improve the, the documentation, and then try to find out how we can improve our system. But again, we brought in the concept of institutional ethics. Whenever we find a gap for an institution, we don't keep quiet. Sometimes we make also recommendations. Now, again, limitation of malpractice and complications. Yeah, we are not as we health professional, we are by to the means, but not the outcome. So if you face such problem and you document in which context you didn't maybe get time to get consent, then that can be considered as negligence. But if you do so and then document, and I think, of course, you will not restrict people to complain, but you'll be saved by the documentation. So complaints may be there, but you know, you will be saved by documentation. And we do receive so many complaints, but some of the doctors, they are not sued because we find that there is no, reason to complain. Complications happen, and we are bound to means, not to the outcome. But again, if you face a problem, let me say you have PPH, triamines, maybe you need also blood, and you don't have the ambulance. And yet you don't shout, you don't call. That is not your responsibility, the responsibility of the leadership, the hospital. And when you keep quiet, you don't call for help, you don't call for help and document right in the file that you called the clinical director at this time and informed him about the need of blood, and you don't have the ambulance, right, those will save you. I give you an example. Recently, I can say it with confidence, a young general practitioner who was affected at Kibagabaga received a patient and advised him to admit him. The patient was in critical condition. The patient refused. And the young man documented in electronic file. The following day, the patient went to Seashika and passed away. And the family came back to Kibagabaga. They said the patient came here and yet you didn't help him and now he's dead. When they called the doctor, he said, no, this patient refused and is documented. And you cannot falsify or can change in the electronic system. And the family kept quiet. That gentleman was saved by documentation. So documentation is very important. Take your time. You know we are overloaded, but as long as the patient came to you, please. I used to tell my colleague, we need to have empathy with the patient. But on the other hand, any patient is a potential medical legal case. So think about it. Incident and malpractice. Incident is not necessarily a malpractice. But when there is an incidence with component of negligence, then that is malpractice. Or if you do something beyond your scope of practice, again, that can be dealt as malpractice. Again, to our mentors, try to tell the young GPs in the district where we are mentoring them that they should know their limit. Because when we are conducting investigations, you find that a GP can perform a C-section on 3 previous scars with confidence, said, okay, I used to do that. And when it comes to, turn bad with complications, he said, we used to do that. We used to do that, but when it comes to, to investigation, you'll be sued because you did it in a city of Kigali, in a hospital where they have gynecologists, and you didn't call, you didn't consult. Those are the soft skills that are lacking, and you didn't have even the courage to transfer to the nearest hospital where they have many gynecologists. So again, operating beyond the scope of practice, that is the common practice you are seeing around, because these gentlemen, they pretend to be confident enough, but you are trying to educate them. So they should not, I mean, have overconfidence unless they are in the rural area. Thank you very much.
Thank you, Chair. We'll have Dr. Honeycomb discuss a little bit on including leadership in the curriculum.
Thanks very much. First, to Dr. Subira, you mentioned the word transformation when you're talking about Rwanda. I think that applies even more in leadership. The practice of leadership is really transformational rather than perhaps the technical term that is used, transactional. There is a lot of transformation that has happened in Rwanda. I think it's only fair to acknowledge what has happened over the last 10 years, immense, and I'm very, very proud of it as being the beacon for Africa and for the neighboring environments. With respect to leadership, it's a concept that I'm really pleased that the society has given it some space to think of and consider, as much as what my colleague has talked a lot about ethics. These are elements, it was raised by a previous colleague in the audience, yes, has to be taught earlier on in the curriculum, and I would feel perhaps the place for it is more at the medical school rather than residency, where perhaps things have really started shaping up. There is a lot of training for leadership that is available, and I'm sure RSOG could really be taking the lead on that aspect and provide leadership training for not only the medical colleagues, but because we work in a team with all the associated professionals in the team, so to speak. Thank you.
Thank you very much. And I'd like to thank the panel and the moderator. In the interest of time, I had to come here. Would like to announce this. So we have a coffee break, but there's no break. It just means we're going out, pick the coffee, come back. The protocol team and ourselves, that we're going to help you. If you pick your coffee and your snack, you're not going to stay outside and chat, you come back immediately. And the second one, we have the feedback QR code on your tables. Please scan that and tell us how we can improve our conference. And my humble opinion on the malpractice, I think as obstetrician and gynecologist, the malpractice insurance is long overdue. Like, if we practice obstetrics and we do not have an insurance, we're just like calling for bankruptcy and jail time. So if we can get the insurance as soon as we can, I think it will change a lot. Thank you so much. Let's appreciate the panel and go back and take a cup of coffee.
Thanks, my brother. That's very good. Important topic.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries, and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in, small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Thank you so much for your introduction. I am honored to moderate this session where we will have research results presentations. I want to invite our first presenter. I think she's there. Dr. Rita Mukashaka from HDI. She is working currently as a research coordinator at HDI. Her background is in clinical pharmacy, and her interest is in research aimed at providing evidence-based resolutions to global health challenge. So please help me to welcome Dr. Rita Mukashaka.
Hello, good morning, everyone. I hope I am audible enough for everyone. My name is Rita. Thank you for the beautiful introduction, Doctor. I am research coordinator at HDI, and I'm very, very honored and pleased to present to you some of the work HDI has been working on in regards to reproductive health. So we carried out a study. We were looking at the non-legal barriers to safe abortion in Rwanda, but we worked with only a few districts. So future researchers will look at other districts here. So why are we, I will not really go into definitions and different aspects of abortion, because I believe I'm talking to specialists who even know more about these things than I do. So why are we looking at safe abortion? Well, WHO says among the unintended pregnancies that happen globally, 60% end in abortion, yeah? And 97 of the induced abortions, which are, I think, 13% in Africa, are all unsafe. And 41% of these unsafe abortions annually are among adolescents and young women. So we can all agree this population is at risk and needs help, yeah? So WHO, this year's report showed that in East Africa, 1 in 7 maternal deaths is due to unsafe abortion. So clearly something needs to be done. Rwanda has made significant progress towards abortion. They've decriminalized abortion in different circumstances, and that's rape, incest, forced marriage if you're a minor, or if there is a health risk. So one may wonder, now that we have progress, now that we have legal perspectives towards abortion, can we say now accessibility and sustainability is okay? I think you can all agree with me that it's not. There is still lack of utilization and accessibility. And this is evidenced by different studies, one that was done in Rwanda by Sabgasoni and colleagues. They did it among healthcare providers, looking at their lived experience while they provide these abortion services. Among her results, the results of the study was that there is still a problem with the utilization and accessibility of abortion services. And that's exactly why we did this study. We wanted to see, yes, there is legal provisions, but then why is it that people still don't access them? People still don't utilize them, and we are still losing mothers to unsafe abortions. So how did we do the study? The design was phenomenological, just to see the lived experience and the non-legal barriers. We did it from Nyagatare, Kicukiro, Gatsibo, and Nyarugenge. This is because the 2018 survey showed that these districts had the highest teen pregnancies. So we don't think there were better districts to carry out the study than these. Of course, we sought approval from RNEC before we carried out the study. You know, the whole ethics side of research. We also sought approval from the different health facility directors, and of course consent forms for people who are allowed to participate in our study. The population was adolescent girls and women, obviously, who had previously sought abortion services or who were currently seeking safe abortion services, whose parents or participants, for those ones younger than 18, part of the ethics, you have to get the assent from their guardians or parents, and that's exactly what we did. Among our population were still healthcare providers, religious leaders, relevant CSOs, and community leaders. because we wanted to get the whole aspect from different angles and how all these influence people while they seek these services, yeah? And in total, we had 24 in-depth interviews, 4 focus group discussions, each with 8 participants, and 10 key informant interviews. How did we do the study? How did we collect the data? We worked mostly with, like I mentioned, with health facilities. The hospital director might not know all the patients or the clients that come for these reproductive services. But we can all agree the sexual reproductive officer will know these people because they're the focal persons. So we worked with them. They invited the eligible members, and those who consented were taken privately to where we could collect data from. Some of them were not comfortable, and those who were not suggested where they were more comfortable. I mentioned the key informants and FGD interviews were all developed using the socio-ecological model framework. This is a qualitative data framework that looks at different stakeholders of the subject in matter to see how it influences your participants. For analysis, we used NVivo, the software, but this is a stepwise sort of analysis. It was thematic analysis. And we did coding using NVivo. The preliminary or the codes we had gotten from the transcripts, we categorized them and checked them against raw data so that we could come up with new themes. Results, what did we find? What did we find as the non-legal barriers? If you look at the demographics, our participants were in the age range of 15 to 30 years. Most of them were single. Fortunately, some were married, and others were divorced. 37 of them were employed, a few of them were students, and more of them were in informal sector. The biggest percentage was from Nyarugenge and Gatsibo. So we found the analysis gave us 2 major themes. The first one was service availability and accessibility. Now these themes have different sub-themes under them. One was an availability of safe abortion services, not just the services, but even the tools, even the personnel. Basically, they were unavailable. To quote a few, a 20-year-old woman said, when I arrived at the hospital, I approached one of the doctors and waited for her assistance, but she was unavailable. Then I sought help from other doctors. They directed me to the same person, but she advised me to seek assistance somewhere else. This led to a significant waste of time, and despite my efforts, the day I received no help. We can all agree when someone is seeking safe abortion, they're desperate. They actually need it. So when you get to the hospital and they're tossing you around, and in the end they actually tell you, find it somewhere else. That's really not a very good way of, The other one was absence of these services in the proximity. These services are usually available at the district level facilities. So if someone cannot get there easily, it's quite hard for them to get these services. There was limited awareness and misinformation. Most people didn't know about these services. You could talk to someone, they're even in the eligible people who can get these services, but for them, they don't know. They didn't know. They only got to know about it when they actually needed it. This particular person said, I believe the main issue is lack of information and support provided to people seeking safe abortion services. Many are fearful of legal repercussions because they are unaware of the process and their rights. This was a 24-year-old from Chichichiro. And people have different misinformation, by the way. They have these myths and beliefs saying, some people are mentioning, I thought if I had abortion, I would never be able to give birth again. Or I would become infertile. So even the negative practitioners' beliefs, the attitudes of doctors was one among the barriers, because it's not just about the service you give, but even how you give it. So I'll rush through for the interest of time. Some had issues with confidentiality. They didn't feel like the information was confidential. Others had negative influence from their friends and guardians, which was a barrier to them, because if your sister or your mother tells you, no, you won't do this, it's really hard for someone to actually do it. Then financial costs. So if we look at our results, they are similar to what has been done in other countries, really. We are not the first ones to do these things, and our results are not exclusive to us. What has been done in Kenya, Ethiopia, India, and others show that there's been an availability of these services. People don't know about them, and there's still a lot of stigma attached to this. Conclusively, we have legalized abortion in very important aspects, but there is much that needs to be done to protect women and children, adolescent girls, to actually achieve optimum reproductive health. So recommendations from the participants, comprehensive counseling services, both pre and post-abortion, youth-centered education, improve community awareness about abortion in cases where it's necessary, financial assistance programs to the people, the women, and even CSOs, capacity building for healthcare providers so that they know how to give these services, not just the skill, but even their attitudes towards it, and monitoring and evaluation of these services. Thank you very much for your time.
Thank you so much, Dr. Anita, for talking about barriers, because barriers are there, I know very well. And meanwhile, I thank HDI for the study. Thank you very much. Let me ask Dr. Simeon Turatsinze to come for the presentation on accessibility, acceptability, and readiness assessing healthcare providers to implement the FIGO pregnancy passport at Muhima District Hospital in Kigali, Rwanda. So welcome, Dr. Simeon Turatsinze.
So thank you very much. Who knows FIGO pregnancy passport in the room? Anyone who knows this tool, FIGO pregnancy passport? One, it's amazing. A room of gynecologists and obstetricians, but they don't know this tool. It's true, it's new. It's relatively new tool. That is the reason why maybe most of you don't know about it. So it is a tool which is still in the pre-implementation and pre-validation category. So we did a study at Muhima District Hospital. We assessed its acceptability and the required resource to implement this tool. So pregnancy can be an amazing moment, but is not off of the risk. You know, apart from this pain of the labor, it is also associated with triple and double the risk of kidney disease, hypertension, stroke, diabetes, and so on. So in Rwanda, we saw the increase of NCD-related death in the last decade, where in most of the studies done by our Professor Ruiz, we saw that cardiometabolic risk of the pregnancy are at high incidence, 3.2%, 11.3% of gestational diabetes and hypertensive disorder of pregnancy. We also saw that among all the transfer to the tertiary hospitals, 28.6% are due to HDPs. However, there is a lot of interventions that has been shown to decrease those risks. You can see a lot of a list which is not exhaustive. But despite all of those interventions, so we still have lack of the comprehensive protocols. You can see isolated intervention, but we don't have the protocol to compare all those interventions. That is where FIGO pregnancy passport is coming in. So in Rwanda, there is no rational burden about the cardiometabolic risk among the pregnant women. So we believe that this study will establish the baseline for the future piloting and implementation of this tool. So our objective were to evaluate the level of screening of cardiometabolic risk, to assess the acceptability of this new tool, and to identify the possible required resource to implement this tool. So we did this study at Muhima District Hospital. Everyone knows how busy this hospital it is. That is why we chose it. So it is a hospital which have around 10 to 12 deliveries per day and 148 beds capacity. So we did a multi-method study, so where quantitatively we evaluate the screening and qualitatively assessed acceptability and required resource to implement the tool. So we did screening of the mothers in postpartum, and we also compared, we checked their electronic medical record and we compared our findings based on the cardiometabolic findings. What we found used the FIGO and what did healthcare providers find using the electronic medical record. So, and after we did a focused group discussion and the key informant interviews, where we did the free focused group discussion and 2 key informant interview to assess accessibility and the required resources. So our measures was including the percentage of the cardiometabolic risk catched by FIGO and those catched by EMR. And qualitatively, we used the consolidated framework of implementation study in its 4 domains to assess acceptability and the readiness to implement it. So as a result, we screened 489 women. Most of them were recovering from C-section, were in 19 to 29 age categories, cohabiting, finished the primary or secondary school, and were in UBD category 2. So our key findings were that using FIGO, we were identifying 10 times more cardiometabolic risk compared to those which were found in the electronic medical record. You can see how this tool is very efficient. So go in detail of the cardiometabolic risk. The EMR was found preeclampsia as the predominant one at 7%, whereas with the FIGO, we found that the family history of high blood pressure was the very highest one at 81%, but surprisingly with 0 record in the electronic medical record. So for the recommendation, we saw that the current practice highly recommend breastfeeding, hygiene, medications, and so on, but all of those are based on the best practice of the postpartum, not necessarily on the cardiometabolic risk. So with the EMR, with the FIGO, we recommended all the best practice at 100% of our participants, apart from the rendezvous which was reserved for the mothers with cardiometabolic of pregnancy, which were at 43.7%. So, and you can see where EMR and FIGO has the same recommendation. Consistently, the FIGO was outweighing the EMR. So qualitatively, we had 3 films. So we saw that healthcare providers view cardiometabolic disease of pregnancy as important, but the management is very varied. So, and we saw that lack of knowledge about cardiometabolic disease and the risk of pregnancy, so in the relationship between NCDs impact healthcare providers' delivery and the health-seeking behavior. Lastly, despite the resource limitation, healthcare providers considered and recommended the ways to adopt FIGO pregnancy passport. So I have few quotes that explaining those films. I'm not going to read all of them in interest of time, but you can see the quotes where the healthcare providers were showing how they see cardiometabolic risk, how the approach vary, how they considered FIGO pregnancy passport as a positive change, and how they demonstrated the capacity to adopt it. And you can see how they showed that the knowledge will impact the follow-up, and they are the one who are in charge of educating the mothers. And they showed the challenge where they stressed that the lack of financial will be the major challenge and the need for the some laboratories. And you can see how they recommended to integrate the NCD's clinic and the health, community health workers in this implementation of this tool. So we saw that the EMR recommendation are mainly the best practice of the postpartum, not necessarily addressing the NCDs. And we can see that we can agree that EMR is used inefficiently. If you can use it in efficient way, you can improve a lot. So, and the FIGO pregnancy passport has been viewed as acceptable because mainly healthcare providers like those screening and management tools because they consider it like a reminder. So it's good to use a tool instead of using your general knowledge. So, and the healthcare providers was the one who showed that their education will impact a lot on the implementation of the tool. So in accessibility to the laboratories, we saw that is a common finding in resource-limited settings, maybe due to poor health financing. So, and we saw that poor financing coupled with knowledge and poor education negatively impact health-seeking behavior. But despite all of those, we saw that if we can use what we have in an efficient way, we can improve the way we screen our patient and we deliver health system. So the limitation of this study, FIGO pregnancy passport being not validated and no gold standard was the primary limitation. And the other limitations that this study was done by the research team, not healthcare providers. Maybe healthcare providers can see something different. And we did on one center, so we need more studies to validate the tool and to implement it. So as a recommendation, we widely recommend to improve the use of EMR, and we also recommend to improve access of the laboratories in order to implement this tool. And during the next piloting tool that I call upon you to do, so we recommend that healthcare providers will be the one to do it. And we need to assess patients' point of view of this tool. And we recommend also assess the community health workers' impact on sanitation of the community as they recommended. So the implication of this tool, we hope that this is the evidence that can show that EMR needs to be improved, to be used in the screening, and it can support the adoption of the FIGO pregnancy passport here in Rwanda, or to expand the MOH guidelines to include long-term screening for this. So as a result, this is something I'm proud of. This tool is already in Kinyarwanda. This is the first tool of the FIGO to be in Kinyarwanda. It is already translated in Kinyarwanda. You can see the Kinyarwanda version of the FIGO pregnancy passport. So as a summary, so the current practice is primarily focusing on the current pregnancy. So we need the guidelines that look beyond the current pregnancy. So we need to see the pregnancy as the opportunity to improve the women's health, not focusing on the primary outcome. So we also need the guidelines that reflect the link between pregnancy and the NCDs. Finally, I'm glad that healthcare providers view this tool as the important one. So together, pregnancy can be a present, unique opportunity in the life course to improve women's long-term health instead of focusing on current outcome. Thank you very much.
I thank our presenter for the nice presentation and really for respecting time, which is very good. You can join the stage there. And I ask also the first presenter, Dr. Anita, to join the stage for questions. So meanwhile, I am calling Assistant Professor Times Jane Arusi. I apologize if I don't pronounce it well, to come for the presentation on prevalence and the predictor of low 5th minute APGAR score among mothers who gave birth through cesarean section at Wolkit University Specialized Hospital, Guraj Zone, South Ethiopia. So please help me to welcome Dr.
Okay, thank you. Actually, you pronounced well. It's not good, but it's good. It's well. So, thank you for this opportunity to present my abstract on predictors of low 50-minute APGAR score among mothers who give birth through cesarean section at Wolkito University Specialized Hospital, Gurage Zone, Ethiopia. So this will be my outline. So the background, just to give the background, the APGAR score, as we know, it's a rapid assessment of the neonatal status, clinical and physical status of the newborn after delivery in the first and the 5th minute, which has been in the clinical practice for the past half a century after 1952, which was at which time it was proposed by Dr. APGAR. And this APGAR score has significance, clinical significance. One is it's a convince, it's easy and easy with cost-effective and simple method of reporting the neonatal status. At the same time, it tells us about the response for our resuscitation in the first minutes of life. And again, sometimes it will guide us for the next management during our resuscitation. So this Apgar score has the cut point of, it has 5 compartments, 5 parameters out of 10. If it's less than 10, we consider it as low Apgar score, which has significance on predicting the neonatal, long-term, short-term neonatal outcome. And there are other parameters, but Apgar is a good, simple and cost-effective and good at predicting the short and long-term outcome of the population outcome especially. That's why Apgar is better than other parameters like metabolic acidosis, like cord blood pH, which has been tried, but this one is, Apgar is better than the cord blood gas analysis. So why we choose the 50-minute Apgar score? The 50 one, we have the first and the 50-minute Apgar score. Usually the 50 minute is good at predicting short and long-term neonatal outcome. What I want to emphasize here is the Apgar score mainly, it's not good at predicting individual neurological outcome or individual neurological outcome, but it's good at predicting the population outcome, and it's not directly related with fetal asphyxia again. In diagnosing fetal asphyxia, the pH, cord blood pH is better than Apgar score, but it's poor at predicting the neonatal outcome. So then, if the 50-minute Apgar score, it's one of the good predictor for neonatal outcome, so it's better to study those factors which can affect this 50-minute Apgar score in the study, and if they are modifiable, we can modify through our obstetric interventions. That was our aim on research. So our research question was, what are the prevalence and the factors, what the predictors of this low 50-minute Apgar score? And the objective is to identify the prevalence and the factors related. Our study area was Gurage zone, which is around 160 kilometers south to Addis Ababa, the capital of the city, and which has one specialized hospital, Wolkite Specialized Hospital, which has around 300 deliveries conducted per month. Of these, 38% cesarean section, emergency cesarean section, and we designed this prospective, institutional prospective cross-sectional study was conducted with sample size of around 270 sample size. We got this from a study at Debra Tower, one hospital, some hospital in the northern Ethiopia. So after the data analysis was, we took all factors on the bivariate analysis, and finally we did multivariate analysis to identify those factors strongly related with low Apgar score and with p-value of 0.05. So the result, let us see the overview of the result. The prevalence is around 27%, 27.6%, and to see the characteristics of the population, as you see, the maternal age group it's almost similar with the young population. It's around between 20 to 35 mothers. Almost all mothers, 90% of the mothers were within the range of 20 to 35 years, and the median age is 26. We can see from this almost half were housewives, and level of education is around 80% were reached out to diploma, and when almost 99% have antenatal care coverage, and 78% are at health center. Then the follow-up was at center. To see some characteristics, almost 92% were fetal presence were vertex. This is time of operation. Duty hours, almost 56% of surgery was done at duty hours. The duration of labor, we can see the graph, the median is around 11 hours. And the skin incision delivery time, again, the median is around 5 minutes. The time interval between decision delivery, it's 40 minutes was the median time. And the referral, from the time taken from referring institution to the managing institution around the median is again 2 hours. And the indications, when you see the indications, almost more of the indication for fetal distress than previous cesarean section and malpresentation, it's the same. So the population characteristics is the same as other population characteristics. So when it comes to the result, final result, so factors related strongly were previous uterine scar, fetal weight less than 2.5 kg, and duration of labor more than 24 hours. Fetal heartbeat, both tachycardia and bradycardia and meconium stenamicrete were related. So others were not related, like obstetric complication type of anesthesia, obstruct labor. They are not related with multivariate analysis. So the final result is the prevalence is 27.6. These are the factors related with low 50-minute Apgar score. So when it comes to our discussion, the new finding is the previous year's CAR. I couldn't get any research relating this low 50-minute Apgar score with previous cesarean section. But those all other parameters related strongly. Fetal heartbeat, meconium, sternoamniotic fluid. There are many studies supporting this result, and the prevalence a bit higher than other studies in our country. And there are also Nigerian studies around 30% prevalence, and some studies in Ethiopia 31%. So this prevalence probably because of we include only emergency cesarean section, ladies, and that our almost 56% of cases were referred cases. That's probably maybe the reason for elevated high prevalence. So regarding previous cesarean section, we try to search why the previous cesarean section is related with this one, and we try to see there are many studies showed that the incision delivery in previous cesarean section is a bit elevated. So in our study, we try to run that, and it's around 5.7 minutes. So it's not statistically significant, but it's a bit higher. And the incision delivery also regarding previous cesarean section is a bit higher, but it's not statistically significant. We didn't get any significant reason. So our conclusion is the finding is higher Apgar score. We have low Apgar score is a bit higher, and there are factors related. So enhancing, if you see the factors, almost all factors are related factor, intrapartum factors, especially low labor duration, meconium stay, and fetal distress, which can be modifiable by improving our intrapartum quality of obstetric care through provision of it can be scaling up of the professionals' knowledge, skill development, skill improvement, or provision of the materials needed for doing cesarean sections, because the incision delivery time is a bit higher in our study. It's around 40 minutes, and decision delivery, and there are also cases for referred cases median. If it's though the median is 2 hours, there are some cases which came after long duration of journeys. So this my recommendation is to enhance obstetric intrapartum and care, neonatal care, through which we can modify those factors. Thereby, we can reduce the low Apgar 50-minute low Apgar score, which is a very important predictor on the neonatal and long-term, short-term neonatal outcome. So these are my references. Thank you. If you have any question, welcome.
Thank you, Professor, for your nice presentation. You can also join the stage. So the time is not on our side. Let's take 3 questions only for our presenters. So who have questions? You can raise your hand. Then just 3 questions. Yes. Sorry. Yes, go ahead, doctor.
Yeah, thank you to all presenters. My question is directed to Prof. Of course, Apgar, we agree Apgar is cost effective, and all these times been helpful. But in a situation like in your hospital, I believe cord blood pH analysis should have been also to help, probably for pediatricians, for future follow-up in case of long-term adverse outcomes. So in case of a low Apgar at the 5th minute, I would believe that cord blood pH should have been necessary for future follow-up of the infants. Thank you.
And I can also remind that you should be short on the interest of time. Try to be short. Yes, go ahead.
Thank you very much.
My question is to the last presenter. I wanted to find out how did you select your variables? Because I'm not sure if I missed the variables like gestational age, even the level of surgeon who operated the case, amongst many other variables. So I don't know how you selected these variables to put in your analysis. Thank you.
Yeah, thank you. My question goes to Rita, and I'm sure you are unable to answer my question. Intentionally, I want to ask it so that doctors can discuss it. We started about self-abortion issues since 2012. And your study has revealed things we know, that doctors don't want to do it. What do you think is the cause? Why these doctors are not doing it? So the law is there, and self-abortion is there. Why can't you practice self-abortion? What's wrong with you doctors? Thank you.
I think if you need the help, you tell us. Yes.
Thank you very much for the question, and really thank you for saying I can't answer that because that gives a platform for everyone to address that question. At least think about it, because why aren't you guys doing it? Why aren't you people helping people that need the help? Because I know this is attached to people's beliefs, doctors' beliefs, and their attitudes. A doctor says, I can't do that. Yet you actually see the woman needs it. So this is a question that goes to doctors beyond this room. Please, give people the help. Go beyond your own beliefs. When you saw the oath, go beyond it and actually help people. I think that's all I can say about the question. Thank you very much.
As I am a moderator, I think I can add also something. Yeah? What I can help, I know very well my colleagues, doctor in Rwanda. They fear, but they fear nothing. That is the problem. They fear nothing. We have put everything in place. Guidelines are there. The law, we always, among us gynecologists, discuss about the abortion law. We have the ministerial order, which guide us how to implement, but still people are fearing. Are fearing what? I think it will be another seminar. It will be another seminar to discuss among us what are we fearing, because everything is there in place. Thank you very much.
Okay, thank you. Let me start from the last question. The reason I was rushing, when I start my background, he showed me like you have 5 minutes. Then that's why I was like jumping to the final result. Otherwise, there are all data. I just showed the important data like incision to delivery, this time decision to those data that the new finding. I want to show you the details. Otherwise, there are parameters, as you said. There are classification based on fetal gestational age. We try to use the best existing gestational estimation of the variables. If you get early ultrasound, we use that one. If you don't, we use last normal menstrual period. Again, if you don't, we roughly use the maternal, other parameters to estimate gestational age, and the fetal weight also the same. So it's included. Fetal weight is included. Below, we classified it as below 2.5 kg, within 2.5 up to 4 and above 4. Classification was like that. And fortunately, there is no very low birth weight babies. Those babies, usually the issue of Apgar score on those ladies, on those babies come to question because of very low birth weight, and the prematurity, again, by itself can affect the Apgar score. So we have included the fetal weight estimation from the ultrasound fetal weight estimation. And regarding cord blood gas analysis, if that's correct, thank you for the feedback. it's usually recommended to do not only this cord blood analysis, so the other parameters like organ function tests are also recommended to, because my point was UPGAR score is better than this cord blood gas analysis on predicting the population neurologic population outcome or long-term, short-term morbidity and mortalities. It's better than the cord blood gas analysis. Otherwise, this is mandatory. It has to be done. And again, perinatal asphyxia is definitively diagnosed by this method. And subsequent organ function tests are also electrolytes, those are things are needed. Thank you for the feedback.
Just the last question to our presenter, Dr. Simeo Turatsinze. So, in one word, the impact of the pregnancy, the FIGO pregnancy passport on our health system, on our hospitals in Rwanda, in one word, what can you say?
So hard one word, but the impact of this is to do not consider pregnancy on the primary outcome of today, but to consider it as to impact the overall health of the women, to look on the screening and follow-up for those who have cardiometabolic risk, so that they cannot have the NCDs, whereas we have a window to detect it and to follow up them.
Thank you so much. Help me to thank our presenter while they are going back to their places, sitting place. Thank you very much.
I can proudly say that we're doing amazing on catching on time. Thank you, the presenters. And we are heading to the next session, and our moderator is one of the people who have actually traveled the biggest forest in the country to make it to Kigali. So he's a junior obstetrician and gynecologist who is interested in research and who is also working on different projects within the RSOG. Please put your hand together as we welcome Dr. Basonga from Bushenge District Hospital.
Thank you, MC. So at this juncture, allow me to welcome two speakers, and the first one being Dr. Chan Grace. So as she comes forward, Dr. Chan Grace is a urogynecologist from Baltimore, the Johns Hopkins University. So the CV is very long. She's a professor with over 100 publications. She's a leader, a researcher, among others, to mention but a few. So please join hands as we welcome Dr. Grace Chan for the presentation. So as she gets ready, we can also welcome Dr. Thomas. He is our reproductive endocrinologist based at Rwanda Military Referral and Teaching Hospital. Please, you can project his bio as he comes over.
Thank you very much. Good afternoon, everyone. You can project the PowerPoint. So today I'm asked to present on assisted reproductive technology, which is a very vast topic, but I will try to do justice in 30 minutes. While we're waiting, I think the previous issue about abortion is very important, and that's one of the challenges that we have passed in Ethiopia. And the way we try to deal with it is, one, by starting a subspecialty program in family planning and abortion. I think that's very important. And also to have value clarification sessions among health professionals. Most of the time, the health professionals are not comfortable because of their religious beliefs to do these things, and we can select those who are comfortable and refer patients to those who can do these procedures. Otherwise, our women will keep on dying and will keep on having complications. So I think this is something that we should really work on as a society as well. I think my presentation is lost. Yes. Okay. So I have no conflict of interest to declare. This will be the contents of the presentation. So the objective of this session is to understand the process of ART, because any general OBGYN should know what ART is, should know the steps in ART, because they should counsel the patients before referring them, even if they are not doing it, to be able to select appropriate candidates for ART, and to be familiar with what we can offer in Rwanda. So assisted reproductive technology is defined as any fertility-related treatment in which eggs or embryos are manipulated. So by this definition, IUI or intrauterine insemination is not included in assisted reproductive technology, because we only manipulate the male gamete, which is the sperm. So it includes IVF-ET or in vitro fertilization with embryo transfer, either with self or donor gametes. It also includes ICSI, which is a technique that is developed in the 1990s, intracytoplasmic sperm injection, mainly for male factor infertility. GIFT and ZIFT are largely obsolete nowadays. We usually do them if we cannot transfer the embryo through the cervix, when there is cervical agenesis or vaginal agenesis, then we can do laparoscopy and transfer either the gamete or the zygote into the fallopian tube. And the last is frozen embryo transfer, which is a quite common procedure. So ART was first done in 1978, and in the following year, in 1979, the first baby, who is Louis Brown, was born. It was a highly inefficient practice early on, because we used natural cycles, but later on, as there are advances in IVF, the efficiency and the pregnancy rates have really risen in the following 40 years. So when we talk of indications, the most common indication for ART is tubal factor infertility. Both unilateral and bilateral tubal obstruction is an indication for IVF. Although in setups like this, we tend to do tuboplasties. Tuboplasties are common procedures, laparoscopically, sometimes also open. Their efficacy is quite low, 1 to 3%. So most of the time, patients should be offered ART, and if they cannot afford, and depending on the degree or severity of the tubal disease, they can be offered with tuboplasty. In standard guidelines like ASRM, what is recommended is for unilateral tubal blockage and mild to moderate tubal disease, you can try tuboplasty if the patient is young and has good ovarian reserve. Otherwise, go for ART. Another indication is male factor infertility. Azoospermia, severe oligospermia, or astenospermia are also indications. Diminished ovarian reserve, ovulatory dysfunction with long duration of infertility. Long duration of infertility meaning more than 3 to 4 years, unexplained infertility, premature ovarian insufficiency, and menopause. In these patients, we use donor egg to do IVF, so we have to do ART. Patients who need gestational carriers because they have contraindications for pregnancy or they don't have uterus, like in MRKH syndrome, also need assisted or artificial reproductive technologies. Genetic disorders like sickle cell anemia or Tay-Sachs disease or cystic fibrosis can be prevented in the offspring by doing pre-implantation genetic testing and selecting the embryos that are not affected to be transferred. So those are also another candidate. Fertility preservation either for oncological reasons, meaning cancers like ovarian tumors early on in women or testicular tumors. Before we do the surgeries, we can save the gametes and do ARTs or IVF later on. Elective gamete freezing is also nowadays very common because women want to postpone pregnancy, so they freeze their eggs early and can get pregnant later on, even in their 50s. So that's also very important. Advanced maternal age or women's age. And single individuals and same-sex couples, depending on the law of the country, can also be an indication for ART. So the take-home message is the indications are quite diverse, and individualization is very important. In our practice, what we see is that patients are offered with fertility treatments like ovulation induction, letrozole, Clomid, and they take that for years, and there is no logical progression in the fertility treatment or plan. So we should offer them for a certain period of time, maybe for 6 months. If that doesn't happen, or if pregnancy is not happening, then you should progress to IUI, then IVF, and so on. So it's very important that we don't waste patients' time and try to individualize the cases. So before we go to the steps in ART, just a reminder that the normal physiology is tailored to produce only one egg in one menstrual cycle. But what we want to do in IVF is to have as many eggs as possible, because the more the eggs, the more the embryos, especially if we are going to do frozen embryo transfer. So the method by which we do this is called controlled ovarian stimulation. So we use exogenous drugs or injectables to increase the number of follicles that we get in a given cycle. And for that, there are different protocols, all these protocols, long, short, minimal stimulation, and so on. There are more than 10 protocols, but the most common ones are the short and long protocols. And from the two, the short antagonist protocol is the most common protocol that we use because it offers a lot of advantage, especially in decreasing the rate of one of the feared complications during controlled ovarian stimulation, which is ovarian hyperstimulation syndrome. So an ideal protocol should produce good quality and number of embryos, should have minimal side effects on the patient, short and easy to schedule so that we don't consume the patient's time, and it should also be cost effective. But no criteria has all these four things fulfilled, so we tend to individualize as well. So what is the ideal number of oocytes to retrieve in one cycle? This question was answered in a seminal research done and published at the Journal of Human Reproduction in 2011. So for fresh cycles, what we want to do, or what we aim to get, is around 15 to 20 eggs. Because as you can see, for all age groups, as the number of eggs go beyond 20, the live birth rate actually declines. And this is because of the high estrogen production during the cycle, which results in progesterone production and premature luteinization, and sort of offsets the embryo and the endometrial maturity. So for for fresh transfers, what we want is 15 to 20 eggs. But for frozen ones, the more the merrier. So as much as we can get, we can stimulate the patient. Then once we get it, we freeze it and we transfer in another cycle. But the most important thing is, if you go beyond the 25 egg mark, there is a chance of ovarian hyperstimulation syndrome, but it can be prevented, and that we'll talk about a little later. So the drugs or the injectables that we use can be categorized into 3: HMG or human menopausal gonadotropin, urofolitropin, recombinant FSH. All these drugs are very expensive, and they carry a risk of ovarian hyperstimulation syndrome, which can be deadly. So they need training and experience to use, so they are not used rampantly. So when talking about the stimulation protocols, the most important one, as I told you, is the GnRH antagonist. Almost 80% of fertility centers all over the world use this protocol. It is short in duration, as you can see. Okay, there is no pointer on it. Yeah, so it's short in duration. You can start the medications on day 2 to day 3, and within 10 days you can perform the egg retrieval. And the most important thing about this protocol is you can prevent ovarian hyperstimulation syndrome by avoiding the use of HCG. HCG is the main culprit in producing patients with ovarian hyperstimulation syndrome, and instead of HCG trigger, we can use agonist triggers, which can completely eliminate the occurrence of ovarian hyperstimulation syndrome. In long protocol or long agonist protocol, nowadays we only use it for patients with endometriosis or adenomyosis because it decreases the estrogen level, and the proliferations of the adenomyomas or the endometriotic nodules is decreased during these cycles. Otherwise, it's not a very popular protocol. So this is just a Cochrane review showing that the live birth rate between the two protocols is the same, but the difference is in the rate of OHSS, and which can be decreased by using antagonist protocols. These forest plots of the meta-analysis also show the same thing. So the next step, once we stimulate the ovaries with these exogenous drugs, we follow the patient with ultrasound. And when the follicles, 2 or 3 of the cohort, reach 18 millimeter, then it's time to trigger. Or if the serum estradiol level is more than 150 picograms per follicle, then we can also, that's also another criteria for triggering. So triggering is important, and we use either HCG or GnRH agonist, as I told you, and we can only use GnRH agonist in antagonist protocol. And the triggering is important because the final maturation of the eggs can only happen if there is LH surge. If you don't give trigger, then the eggs that you retrieve will be immature. After triggering, 34 to 6 hours after triggering, we do what's called oocyte retrieval. Oocyte retrieval early on was done with laparoscopy and laparotomy, but nowadays it's almost exclusively done with transvaginal ultrasound guidance. So we take the aspirates from the follicle and we separate the cumulus oocyte complex and incubate for some hours, then go to the next step, which is fertilization. And fertilization can be done either with conventional IVF or ICSI. With conventional IVF, we just put an egg and around 50 to 30,000 sperm in the dish, and hopefully one of the sperms will go and fertilize the eggs. But with ICSI, we take matters in our own hand, take one sperm and directly inject it into the egg, and that's why the fertilization rates using ICSI is around 70%, which is high. So pre-implantation genetic testing can be done on a day 3 or day 5 to day 6 embryos. Day C embryo or cleavage stage embryo is usually better and has more representative sample. So when we talk of pre-implantation genetic testing, there are 3 types. We can test for aneuploidy, which is PGTA. We can test for monogenic disorders like sickle cell, Tay-Sachs, cystic fibrosis, and so on. Or we can test for structural rearrangements. Okay, so the commonest one is PGTA, which is usually age-related. in women more than 35 years, in women who have previous failed history of IVF, PGTA is indicated, and some centers do it routinely for all patients, but evidence is lacking to recommend for all patients. PGTM can be offered for patients who have genetic diseases like sickle cell anemia or carriers of these genetic diseases, and PGT-SR is usually offered in recurrent pregnancy loss where there is balanced translocation in the parents so that we can select the embryos without translocations. So the last step would be embryo transfer. Embryo transfer is done under ultrasound guidance. It can be using a transabdominal ultrasound or a transvaginal ultrasound. More commonly, we use transabdominal ultrasound with a full bladder, and we transfer the embryos using catheter 1 to 2 centimeters from the fundal edge. And this is extremely important. It's extremely important that the number of embryos we transfer should be limited. Worldwide, what is recommended is elective single embryo transfer. Elective single embryo transfer is done in a frozen cycle, and you test the embryos first, and if the embryos are euploid, then you can only transfer 1 embryos. But in setups where you cannot do PGT or pre-implantation genetic testing, and you don't know the aneuploidy status of the embryo, the maximum you can transfer is 3 embryos. But 3 embryos is also quite rare unless the patient age is more than 42 years and she's using her own eggs. We usually don't transfer 3. So the maximum in my practice we transfer is 2. So for patients who are more than 35 years, who have failed IVF cycles and diminished ovarian reserve, then we can consider transferring 2. But otherwise, with good blastocyst, morphologically, we transfer only 1. Cryopreservation can be done on a gamete or embryo if we have leftover embryos, or if you want to do frozen embryo transfer later on for different reasons, you can freeze the gametes or the embryos. And freezing, it can be almost indefinite. You can keep it as long as the conditions of the freezing are maintained. You can freeze it for years. So there are 2 techniques, slow freezing, vitrification. We use vitrification. It has better results, and actually frozen embryo transfers have better results compared to fresh ones. So that's why the world is moving away from fresh transfers and going to more of frozen embryo transfers. So talking about the complications of ART, the most feared complication, as I told you, is ovarian hyperstimulation syndrome, which can occur in 1 to 5% of patients, but it is totally preventable by selecting the right protocol, which is usually the antagonist protocol. And the pathogenesis is sort of like preeclampsia. So when you give HCG trigger, what happens is in the presence of high levels of estrogen, there is excessive production of vascular endothelial growth factor, which results in leakage of intravascular fluid into the third space. So the patient will present with ascites, pleural effusion, contracted intravascular volume, vomiting, and so on. And it has grades, mild, moderate, severe. And these patients should be treated by RAI specialists because the clinical manifestation is quite similar with congestive heart failure. And if they go to an internist, they will think that it is congestive heart failure and they will give Lasix, and which is actually quite dangerous because the intravascular volume is contracted. So you should follow patients after transfer, and if they develop this kind of complications, then you are the ones who manage it. Usually the management is supportive electrolyte and fluid replacement. The other feared complication and common one is multifetal gestation. Unfortunately, most IVF clinics are almost synonymous with multiple pregnancy, but this shouldn't happen. We should limit the number of embryos that we transfer. Acceptable rate of multiple gestation in a clinic should be 10 to 15%. And in a room of obstetrician and gynecologists, I don't need to talk about the complications of multifetal gestation, which can be summarized everything, all except macrosomia and post-maturity. Yeah? So it's very important that we avoid it. And in case it happens, we can also offer fetal reduction methods. So I believe this is the final slide. So when we talk about ART in Rwanda, the prevalence of infertility in general is not known. There is no nationwide study done so far. It's estimated between 10 to 15% of couples are said to be affected with infertility. And if the burden in our clinics is any indication about the prevalence of infertility, it is a real public health problem. For example, in our clinic at Rwanda Military Hospital, there is a 6 months waiting list for infertility patients to be seen. So I implore obstetricians and gynecologists to join the field. It's a very exciting field. We're trying to have a curriculum approved. Hopefully it will be approved soon. It is under process at HEC. If anyone here is from HEC, please try to move it along. We want to start the fellowship program and help all these women that are suffering from this issue. And our clinic was established in 2018 by Dr. Ngoga, Dr. Theogen, who are the pioneers in this field, and is capable of performing everything except for PGT. So everything we have discussed we can do except for pre-implantation genetic testing. What is a little different is we perform batching. Batching is important in places where there is human resource limitation and drug and consumable limitation. For example, in our setting, there is only one RAI specialist, which is myself, and one senior embryologist, so we cannot keep on doing IVF continuously. So we batch patients using OCP, or oral contraceptives. We stop the oral contraceptives at the same time so that they can see their menses, and we can start the medications. And we do around 40 to 50 patients per batch. And also the consumables, some of the consumables have very low expiry dates, so that's why it offers an advantage. So I think that's it. Thank you very much. I hope I managed to summarize what I want.
Thank you very much. For the interest of time, as he still stands, we can have a question or two from the audience. Thank you.
Thank you, Thomas. I'm not surprised to see this kind of quiet and thorough presentation. I expected it. Thank you very much. I would like you to insist very much on elective single embryo transfer and multiple pregnancies, because as you briefly talked about it, in obstetrics and gynecology were suffering a lot with the multiple pregnancies. How can you help us to stick on the principles of less embryos transfer? Thank you.
Thank you very much for your insightful presentation. I think one of the issues with regards to ART has always been cost. So my question has been, how affordable is it here in Rwanda? Because in my country where I come from, in Zimbabwe, this can see a patient paying up to $5,000 for a cycle. So I don't know how comparable it is here and back home. I'm talking about private practice. Can be anything from 3.6 to 5,000 USD for stimulation, retrieval embryo transfer, and subsequent follow-up of the patient. Thank you.
All right. So for the first question, single embryo transfer, as I told you, single embryo transfer is advocated for all patients, irrespective of age, if you can do pre-implantation genetic testing. If you can do pre-implantation genetic testing, and if the embryo turns out to be euploid, then you can transfer just one. But the problem with our setting is we don't have pre-implantation genetic testing. And short of that, what you are left with is the morphological analysis of the embryo and to transfer based on the risk of the patient, meaning the age and the previous history of IVF. So in our practice, we have a guideline to never transfer more than 2. So we never transfer more than 2 embryos at RMH. Other centers might do different things. I don't want to talk about that because I don't represent those centers. So the maximum we transfer is 2, and our multiple pregnancy rate is around 18%, which is a bit higher than recommended, but we don't have any higher order pregnancy so far since I have started practicing. No triplets, no quadruplets. The multiple gestations are just twins, and we try to limit the number of embryos that we transfer. And increasing the number of embryos you transfer actually does not have a significant impact on your pregnancy rate. It marginally increases it, but when you see the live birth rate, it significantly decreases it. And your endpoint should be the live birth rate, not the pregnancy rate. So some private clinics, they just want the patient to get pregnant, so they dump all the embryos that they have in the uterus, then multiple gestations happen. I'm not talking about here, it's common everywhere in the world. So this is a malpractice issue. Multiple gestation should be as much as possible limited in IVF clinic. Regarding the cost of ART, the cost at RMH is between 3 to 3.5 million Rwandan francs, which translates, I think, to 2,500 to 3,000 USD. It's a little subsidized because it's a governmental or it's a public center, and there are some, I think, amenities that are offered to these government centers. Otherwise, in the private, obviously, it would be higher because the drugs, consumables are very expensive. So it's an expensive mode of treatment, but the success rate is quite high. Our success rate ranges between 55 to 65%, depending on the batch. So, yeah.
Thank you very much, Dr. Thomas. I think this is an interesting topic, and there are a lot of aspiring fellows in the room. So, give a round of applause to him as we welcome the next speaker. So let's have Dr. Grace Chan and team to continue. Welcome, please.
While we're waiting for my slides to come up, I'm Grace Chen, and it's a great honor for me to be here, so thank you for this opportunity. And some of you may know me as a urogynecologist and a reconstructive pelvic surgeon from Hopkins, from the States, and I'm here as part of the IOWTD team, and I know a lot of you are very familiar with this organization. Now, if you guys were here on Wednesday, you also know that I direct our Global Women's Health Fellowship. And of course, 2 of our fellows, one is none other than Dr. Victor, who's the president of the society, and the other one is Dr. David, whom you heard from yesterday. But in addition to that, my other research niche has really been in the area of surgical education and surgical simulation. And I actually do a lot of work using AI, so artificial intelligence methodology for surgical skills assessment. So I think you're going to hear a lot of the common themes being repeated today. I also do a lot of minimally invasive surgery, including laparoscopy and robotic surgery. I don't have any disclosures specific to this talk, but hopefully the technology will work and you'll get a chance to vote. So if you guys could either scan the cue card or you could just type in manually that website. And once you scan it, it'll ask you to register and you can just skip. And then this is a way that you can actually vote and we can see it live during the presentation. So I'll give you a minute to do that. And while you're doing that, my other disclosure include that I've been a consultant, but pro bono, so I wasn't paid for it. But a lot of the research I'll present today have been funded by the U.S. National Science Foundation, as well as the U.S. National Institute of Health, as well as a couple of other organizations. All right. So as a surgeon, especially in countries like the US and others, it's not only enough that we go to medical school, we get a residency, some of us even do a fellowship to become a consultant surgeon. We also must prove that we know what we're doing. So we have to prove our surgical skills. So back in 2018, the American Board of OBGYN mandated that in order to graduate residency, so in order to become an OBGYN, you must pass the fundamentals of laparoscopic surgery. So it's a curriculum designed to test your laparoscopic skills. So you cannot become an OBGYN residency graduate, so you can't be an OBGYN consultant without actually passing that test. Now, the problem with FLS, the fundamentals of laparoscopic surgery, was that it was designed by general surgeons. And I know that we're mostly OBGYNs here, and no offense against the general surgeons, but they do their laparoscopic surgery different than we do our laparoscopic surgery. So then, back in a few years ago, educators such as myself, as well as other universities throughout the US, as well as one in Canada, University of Toronto, designed the Essentials in Minimally Invasive Gynecologic Surgery. So this is a curriculum that's similar to FLS, but it targets both laparoscopic surgery and hysteroscopic surgery. And so the American Board of OBGYN in 2023 said that, well, you know, as an OBGYN resident in the US, you can either pass FLS or now you can pass EMICS. And if you pass either of these, you can become an OBGYN consultant. So again, the best message here is that it's not just, you know, we can't just finish our training and become a consultant. We now must prove our skills. Now, some of you may say, okay, well, this is important, but show me the data, so show me the money. Well, this was a landmark article from the New England Journal of Medicine that basically show that skills correlate directly with complications. So on the x-axis, you can see the surgical skills rating. So the higher number is better, so the better the skill. And on the y-axis, you can see complication rate. So going up, meaning obviously higher. And you can see there is a direct correlation. So the better surgeon you are, the less likely that your patients are to get complications. Is this surprising? Of course not. But it's good to have the evidence. Now, many of you may know see one, do one, teach one. How many of you know this idiom? Yeah, I would say a lot of you do. So this was something that was started by Dr. William Halsted. And he was a general surgeon practicing in the late 1800s. And he's actually one of the founding fathers of Johns Hopkins. And the idea behind this is you see a surgery, you do a surgery, and you teach a surgery. Well, you know, maybe in the 1800s this was enough, but this is clearly not enough, not to mention not ethical now to do, right? And, you know, I don't have the time to go through all the reasons why this is not enough, but obviously our surgeries are so much more complex. And, you know, as OBGYNs, we have to learn so many more surgeries. So now, as I alluded to, we have things like simulation that we can go to learn our surgical skills. And I don't have a pointer, so I'm just going to come and point. To just give you an example, this is what FLS looks like. So this is the fundamentals of laparoscopic surgery that the general surgeons develop. And as you can see, you kind of operate across and everything is down on the bottom. Now, those of you that are gynecologic surgeons know that the pelvis is not shaped like that. The pelvis is not in the bottom. The pelvis is more like this way. So that's why members of myself, as well as other educators in the US and in Canada, develop EMIC. So this is an example of EMIC. And as you can see, instead of everything being down here, it's more, you know, kind of off to the foot of the bed or the foot of the patient, right? It's more anatomic. Now, it's not surprising, I think, to most of you that simulation improves training skills, and importantly, the skills that you practice in the simulation setting are also transferable to the operating room. You know, there's been tens and thousands, if not hundreds of thousands of articles that have shown the importance and efficacy of simulation training. Additionally, as I alluded to, there are many boards and accreditation councils that have mandated simulation either as a form of training or as a form of testing as part of the OBGYN and other residency programs. So in this case, the ACGME, which is the Accreditation Council for Graduate Medical Education, so this is for residents and fellows, in the US require incorporation of simulation training in residency. And it's not just for the operating room, it's also team-based training, it's also ACLS, it's also medical students doing physical exams and doing patient interviews. And it's also important to understand, and this point is really important to me, that most well-studied, cost-effective simulations are actually low-fidelity simulations. So they're low-fidelity models, okay? And a lot of times they're just skills. So you practice, for example, moving things or suturing. They're not entire procedures, okay? And this is actually a picture of an example of that. So this is called the flower pot hysterectomy model. And this is something that we designed and developed at Johns Hopkins. And I actually brought a physical sample here. This takes maybe $2 or $3 to build. It's very cheap, very inexpensive, but it absolutely has been shown to improve surgical skills. Now, I will admit, the hardest part about this model is the time it takes to build it. But this is where you want to maximize your educational opportunity. So usually, I work with medical students to build this so that they understand the anatomy. And then the residents and I would then do the hysterectomy using this. And with this model, you can do a vaginal hysterectomy, you can do an abdominal hysterectomy. In this case, the one I brought today, we even made the uterus large, so you can practice C-sections, you can practice doing different type of hemostatic sutures, like B-Lynch for C-sections. So it really is multiple use. The conference organizers, I think, will be giving you a PDF of how to make a model like this if you're interested. Now, of course, there are also high-fidelity models. So I just want to show you this in contrast. This is an example of a high-fidelity, so a more realistic model that can be used for vaginal hysterectomies. And again, lots of evidence shows that you don't need to go to the more expensive model, that the less expensive model is every bit as effective. All right, so far we've talked about training in the SIM setting. Well, let's talk about the other part of training, which is assessment, right? So we know that it's important to train in the simulation setting, but what about assessing surgery? Well, we can tell that assessing surgery just by having your residents do surgery, that's probably not a good way to assess surgery. And why is that? Because you can't have your residents make mistakes on patients. So it's not ethical to practice on patients. It's also not ethical to make mistakes in patients. And we know that a really important part of learning is learning by making mistakes. And you simply, as a consultant, cannot let your residents make mistakes in the operating room. The other thing that we keep track of in the US, and I suspect you guys do here as well, is how many cases we do, right? The number of vaginal hysterectomies, the number of abdominal hysterectomies. And case logs, they do show your expertise, so they show how many surgeries you've done, your experience, but they don't really tell you how well you did something, right? So you may have 10 hysterectomies, but you may have performed them very poorly, right? So case logs, again, are not sufficient. So I would argue that simulation is another place where you can assess a trainee's surgical skills, because again, there not only can trainees make mistakes, they should make mistakes, because that's how they learn. All right, so in terms of our outline of this talk, we've basically talked about why traditional surgical teaching and assessment is not enough. So I'll spend the rest of my talks speaking on some best practices and evidence-based practices for teaching and assessing surgery. As consultants, we all have very little time, especially you here. You guys see so many patients. The patient need here is so high. So what are some strategies we can use to make that teaching time shorter and more efficient and more effective? And then I'll end by summarizing some of the applications of artificial intelligence and machine learning on surgical skills assessments. All right, so to start with, in terms of assessment, This is an example of a validated global rating scale used for assessment. So this was actually developed by Dr. Resnick, who's one of the pioneers in surgical education at the University of Toronto. And so basically the way this scale works is after somebody performs a laparotomy, let's say for a hysterectomy or even for a C-section, you can assess the resident how well they perform using different parameters. Respect for tissue, time and motion, instrument handling, so forth and so on. And then you evaluate them using a Likert scale, okay? So they go from 1, meaning that they pretty much did poorly, all the way to 5, which is they really did well, okay? And so this scale, or variations on this, have been developed for all the routes of surgery. So laparotomy, laparoscopically, robotically. The only one that hasn't been developed, at least a few years ago, was for vaginal surgery. So when I was a fellow, I developed a global rating scale for vaginal surgery. And it basically looks very similar to the previous global rating scale you saw for laparotomy, except it has a few other parameters. And all of these scales, including mine, have been shown to be reliable and valid. Now, in addition to global rating scales, you can also use a checklist to complement. So a checklist includes different steps within a specific procedure, in this case, vaginal hysterectomy, and it asks you whether or not a trainee has done specific steps. Now, the problem, of course, with a checklist is it doesn't really tell you how well something's performed, but just whether or not they performed it. So I think the best is to use the global rating scale and the checklist together, okay? Now, I was hoping that we can kind of practice using one. Now, I know that you haven't, most of you maybe haven't done robotic surgery, but all the principles of surgery, irrespective of the route, are the same. So let's practice doing an evaluation for robotic surgery. So if you haven't already checked in on the Q code, please do so now. And we're going to look at efficiency. So we're going to see how well is the surgeon performing this surgery from an efficiency perspective. And there are the different parameters. So again, 1 is always the worst, 3 is somewhere in the middle, and 5 is the best. And then if you want to go ahead and vote, and I'll show you the procedure. Hopefully it will play. Okay. So a hysterectomy has already been done. This is the vaginal cuff. And you can see that the surgeon is performing the vaginal cuff closure. And so you think they perform at a 1, or 2, or 3, or 4, or 5. And remember, 5 is the best. And you're just evaluating them on the suturing parts. So the uterus is already gone. This is just the vaginal cuff. All right, hopefully you guys will all respond. Okay, are you ready? Okay. All right, so again, that's the QR code in case you didn't get it before. And then let's see. Okay, no one has responded. Yeah, you just click on it. It doesn't work. Okay, how about let me see a show of hands. How many goes with 1? We'll do it the old-fashioned way. How many think is the 1? Nobody. Okay, 2? 3? Okay, a few 3s. 4? Okay, a few 4s. 5? Okay, so 3, 2, or 4. Yeah, and I would completely agree. This was one of our more senior residents doing it. So I totally agree with that. So again, you know, what this shows is the principles of surgery. It doesn't matter what route of surgery, the principles are the same, okay? All right, and then I just wanted to take a little pause and let you know that there's a lot of resources out there, okay? So you don't have to come up with your own, you just have to search for it. So in addition to all those other positions I hold, I'm also the vice chair of the American College of OBGYN's Simulations Working Group. And as part of that, we have a lot of resources on there. And I know you have to be a member to be included, but a lot of these resources are commonly available and free to everyone. So I would recommend that you do some Googling. All right, and how do we then integrate all of this into practice? So we talked a little bit about some tools, but how do we actually put it all together? So even before the surgery, what I do with my residents is I have them reflect and do deliberate practice, meaning I have them think about their previous case and tell me specifically what part of that case do they want to improve on. Do they want to improve on bladder dissection? Do they want to improve on suturing? What specific part? And in order to do this, and oftentimes we'll do it in a simulation room, you have to make sure that the simulator is close to the operating room. And again, it doesn't have to be an expensive simulator. It can be something inexpensive, but it needs to be accessible, okay? And we do a lot of just-in-time or warm-up training. That just means that right before the case, let's say they're gonna do a lot of laparoscopic suturing, they get a chance to practice that right before the procedure, okay? And there's actually been a lot of data, some of which I contribute to, that looked at warming up right before surgery. And you just do it for 5–10 minutes. And that's actually been shown to improve performance. I think as consultants, we need to set a positive learning environment. This just means that we as consultants need to encourage our trainees to come to us with things that they're having difficulty with and to help them with that. And together, me and the resident should set goals together. You know, say, hey, we want to improve laparoscopic suturing, for example. A lot of times the trainees or the residents have goals that are not realistic. And as the consultant, we need to help them become more realistic. And a lot of times I'll do some mental practice at the scrub sink. So when I'm scrubbing, I'll have the residents talk through the steps of the procedure. You know, so that's called mental practice. So when they're doing a C-section, they go through every step they're going to need to perform. Now, during the surgery, again, set a positive learning environment, right? Make sure if the resident's doing something bad, you don't reprimand them, you just correct them. And then after the surgery, we usually debrief in a simulation room so that if they're struggling with a specific step of the surgery, I can show them how to do it better. And then we together think about, well, what is the next step? So now that your suturing is better, what is the next step you want to improve on? And then the next time we're in the operating room of the theater, that's what we work on. All right, so global rating scales, which I just mentioned for different routes of surgery, is great, right? It tells you about how well a trainee performs during surgery. But the problem with global rating scales, it's a global scale. So it just tells you overall about the surgery. It doesn't tell you specifically what step they need to improve on. They still need me to say, okay, you need to improve on the suturing, or you need to improve on the dissection, right? And obviously all of that takes time. So for the very last bit, I'm just going to talk about using AI to do this. So how can we use artificial intelligence to help us consultants, busy consultants, be able to teach surgery faster and better, okay? And you guys are not surprised that, you know, AI use in healthcare has skyrocketed, and it's also skyrocketed in surgery, and most of it has actually been in skills assessments. And this is my big team of artificial intelligence and computer science collaborators. And, you know, I am not at all tech savvy. If I have a problem with my computer, all I know how to do is turn it off and on, right? So I really need the experts to help me do this. Now, you may think, she's talking about collaboration, and all of a sudden she shows a slide on Imatizi. And for those of you that don't know Ki Rwandan, this is a slide on transmission of chlamydia. So what does collaboration have anything to do with transmission of chlamydia? Well, I show this because collaboration is like transmission of chlamydia. You know, just because if you transmit chlamydia, you still have it, right? Like, you don't just give it away, you still have it. So for the younger doctors in the room, I would urge you to collaborate and collaborate widely, you know, because just because you share your ideas, you still have it, okay? And then I'm just gonna go through this very quickly. So we basically have used artificial intelligence to learn for the machine to automatically be able to dissect the different parts of hysterectomy. So there's different steps in the hysterectomy. And the machine was about 80% accurate in being able to do that. In addition, we've also been able to use the machine to tell us how well something is being performed. So basically, we set a whole bunch of different skills for the machine. The machine is able to learn from it, and then it's able to tell us how well a surgery is being performed. And this is, of course, in a simulator setting. And specifically, you know, the reason why this is important is because here, this is suturing. And as you can see, you know, there's different parts of suturing, like passing the needle and tying the knot. And here you can see that the person performing this has no problems with passing the needle, but they have problems with tying the knot. And as a consultant, I don't oftentimes have time to give them such detailed feedback, but the machine can. The machine can say, okay, you need to really practice on knot tying. You're suturing just fine, but you can't tie knots. And this is just showing that we've also been able to do this in the operating room. Okay, we're gonna actually skip this last one, especially since the poll everywhere is not working. And finally, I just want to end with this. So as a group, we've developed an overview of how we ideally would like to see surgical training. And it's a closed loop of going from the simulation setting to the operating room and then going back to the simulation setting. So as an example, you have a resident practice suturing in the simulation setting. Then you take them to the operating room and you have them suture. And you tell them how they did. And specifically, you know, you tell them exactly what part of suturing they need to practice. Then they go back to the simulation setting, and they practice that specific skill within suturing. And they get better and better and better until they reach a certain level of proficiency. And then they go back to the operating room and do it again. And so it's a closed loop cycle. And after you're happy with their suturing, then they move on to the next step, such as dissection. All right, very good. All right, so in summary, surgical training and assessment is evolving. So it's no longer adequate or ethical to only train and evaluate in the operating room. Surgical data, science, and artificial intelligence are playing and will play an important role, but right now it's still very experimental. And today I've given you some simple tips on how to incorporate surgical teaching and assessment in the simulation environment and in the operating room before, during, and after surgery. And for those of you, again, that are interested, I have one of our flower pot hysterectomy models for you to view. I've also emailed the conference organizers all the global rating scales I mentioned in a PDF for you. Thank you very much.
I'm going to say, aren't you inspired? I think that was so inspirational. And not to take so much of your time, these three speakers are all going to tell us what to do with simulation and how we can improve our practice. So let me ask the AV team to project the bio for our next speaker. Please, AV. Please, because if you, anyhow, so we're going to welcome Dr. Patel. She's going to talk about postpartum hemorrhage, what's old, what's new, what's possible given system changes. You're being led with the bio, please just go ahead with the presentation. Thank you.
Hello, can everyone hear me? Great. Thank you for inviting me to speak to you today. I'm very happy to be here. I'm going to be talking about PPH. So we're getting away from high-level assisted reproductive technologies and high-level surgeries and going down to earth with PPH. Do I get to click or? Oh. Sorry, I forgot about that. Thanks. Oh, it's not up. So I'm one of the Canadian delegation who you've heard of, and we're here to offer workshops that we've been working on over the last year with RSOG. So I just thought I'd just make sure that people understand why we're here and what we've done. last May 2023, we came and worked together with RSOG colleagues to harmonize a curriculum that could be delivered in Rwanda. We have this alarm course called Advanced Labor and Risk Management, and it's a course that's delivered to obstetrical providers in Canada. And it's been very successful. It started 30 years ago. I think I was one of the first participants in the course back when I was just graduated and had planned to deliver babies in Northern Ontario where there is no surgical backup. And so I've been a big believer in the alarm course, and over time, I can't remember, maybe 10, 15 years ago, it was recognized that perhaps the alarm course could be useful in international settings as well. And so we've delivered the course in various countries, in Africa, Bangladesh, India. I believe there's a number. And one of the first things that is done is harmonization of the curriculum to make sure that the curriculum is relevant to the local context. And the other really key feature of the course is that there is a significant amount of discussion and workshopping on sexual health and reproductive rights. And that is fit in to the curriculum around emergency obstetrics, because we understand that the status of women and how women are treated in one's country affects their ability to access care. Okay, so here's Rwanda, and you might be wondering how is a Canadian relevant to the Rwandan context, and what is she going to tell me about PPH that I don't already know, which is a fair point. We have provinces, just like Rwanda, but this is the surprising graphic, is that when you put Rwanda on a background of Canada, Canada is a lot bigger, actually, surprisingly bigger. And so we have this giant country, and so because of that, actually, there are remarkable similarities between the two countries in terms of providing obstetrical care. I used to work there's the Great Lakes down by the border of the US, and that is actually considered northern setting. I used to work there, and it was 3 hours away from the nearest surgeon. There was no blood availability or surgical backup, and because of that, I feel like there's some commonalities. Like Rwanda, births are provided in the hospital or a health center, birth center, or at home. We do have rural and remote care, as I mentioned. We have significant transportation issues. We have witnessed that as a group here. We have gone into the health centers to do some follow-up training and ridden or driven on some of the roads up to the health center. And we too have some transportation issue, not in terms of quality of roads, but snow, and roads can be closed because of weather conditions. We have a universal healthcare system, so costs of healthcare facilities and medications, that's very much an issue in our country. So I was saying that TrueScreen PAP product there's no way we would ever be participating in that because we couldn't afford that. And childbirth care is provided by midwives and medical doctors and OBGYNs. So again, we're going to review PPH. And much of that may be reviewed, but I'll scroll through pretty quickly. And my hope is that we come up with a plan for PPH for Rwanda. So we can, maybe try to continue to tackle that maternal mortality rate. So of course, people know the definition of PPH, primary and secondary. And then the 4 T's that need to be considered, with atony being the major issue in PPH. So one thing that happens, I think, maybe not as consistently and could be improved, and I remember this when I was working in a remote setting, is identifying risk factors. So women who are considered higher risk and who should not deliver without surgical backup need to be identified early if possible. And so having some kind of consistent approach to have the staff, the nurse and midwives at the health centers identify women regarding risk factors would be useful. And actually, I was going to ask, who here has actually delivered babies in a setting without surgical backup. Because you're maybe all surgeons, so you always have your own backup. Sorry? They are the surgical backup, exactly. So like, I can speak to you from a person who is actually a family physician. I'm sorry I didn't mention that. And so I don't do C-section surgery, and so it is a different existence in the delivery room when you don't have surgical backup. And if one could get into the mindset of the nurse or midwife, at the health center, without that level of backup, that would be useful for the rest of this talk. But it is a stressful situation, and I think that it can relate to a lot of burnout and staff turnover, which I think is an issue overall. We have that too in Canada, definitely. We have birth providers who are leaving the care of women. So the old stuff is pretty clear. Oxytocin, as you know, binds to the oxytocin receptors and stimulates contraction. It's available at the health center all the way up to the referral hospitals here. It requires refrigeration. I think when we have been going to the health centers, and it seems like there may be some question about quality of refrigeration. I was able to attend a birth at one of the health centers, and the refrigerator was around the corner where the vaccines were kept, and so I was surprised that the midwife had to leave the laboring woman, and I wondered what would happen if she was alone in the night and had to leave the room to get the oxytocin. So you can imagine a time delay and that sort of thing. So that's one of the perhaps barriers to care with oxytocin. Misoprostol, so this, I've often said this is my favorite medication because I think it's a cheap and effective medication, has multiple uses across obstetrics and gynecology, for IUD insertions, things like that. It is available. It doesn't sound like it's available at the health center level, except if there's a medical doctor health center. Is that correct? Because that's what I understand. We have been to health centers where there isn't misoprostol available. So not everyone is getting access to a second-line uterotonic. It's wonderful because it's stored at room temperature, and I know community health workers have it available for home births. Ergometrin is on your Rwanda Essential Medicines list. I don't know how often it's used. In our workshops, it seemed that it wasn't used that often at all. Has anyone used ergometrin in a postpartum hemorrhage setting here? No, it's contraindicated with hypertension, so that may be partly why. We have used it over the years in Canada. For sure, it's in our postpartum hemorrhage kit. It requires refrigeration too. Prostaglandin F2 alpha or carbaprost is another medication. It's not on the WHO Essentials medication list, and I don't think it's on the Rwanda Essential Medications lists. So we'll just scroll past that. This is Dr. Theodore Mir, who was one of the trainers that we trained during our training of trainers. And he is showcasing the anti-shock garment, which can be used for transportation, and it has been shown to improve outcomes in patients who are bleeding prior to transportation. We have a model actually that we can pull out and you can take a look at it. It is actually low cost and reusable up to 144 times, so it's a reasonable option to consider. And then of course the balloon tamponade options, the Foley plus condom and the Bacri. So I'm going to skip B. Lynch because you're going to get a talk about that next. And so what's new? Now, heat-stable carbetocin, I think most of us were here when the representative from Ferring gave a talk about heat-stable carbetocin, and I was able to review it a bit more. It is, we've been using it in Canada for post C-section uterotonic. So it's used routinely, I think, in many centers post C-section because it's a longer lasting uterotonic. So it can last up to 2 hours. Those are the doses and stuff. So the top study was done actually by Merck. So it was a study comparing oxytocin and heat-stable carbetocin for prevention of hemorrhage after vaginal birth, and it showed as effective as oxytocin. So that was reassuring. And then there's been a Cochrane meta-analysis of all the uterotonics used for active management of third stage of labor or prevention of postpartum hemorrhage. And the carbetocin is felt to be as effective as the other options that we have. So it has pretty good data backing it. Yeah, I think that's... So the issue previously with carbetocin was that it was not heat stable and it cost. So now I think, I was surprised to learn that there's a relationship with Ferring Pharmaceutical and IDA Foundation, and they're offering it to low and middle income countries for 7 cents an ampule. So it's a realistic option for prevention of PPH and active management of a third stage of labor. So the other sort of newer option is tranexamic acid, and we've been using that for about 5 years, I think, in Canada. And it's an anti-fibrinolytic medication, and it stops plasmin from breaking down a clot that may be developing. It's been used a lot in trauma settings. And it's given IV and can be repeated 1 time. There is some work going on in an IM option, actually, in the trauma setting, and perhaps that will happen in the obstetrical setting too, because if you can't get an IV, it's still nice to be able to use it. So the woman trial was the big trial for the tranexamic acid, and that was done in 21 countries, 20,000 women. And it showed a decreased rate of death due to bleeding and laparotomy. And the interesting thing about the woman trial is that the use of tranexamic acid had to happen under 3 hours, because if it happened after 3 hours, it favored actually worse outcomes. So it is a time-sensitive medication. And in that sense, it may be useful to have available at the health center level. So the big trial is the emotive trial that was published in the New England Journal in 2023, in May 2023, and it had over 200,000 women in it. It was set in 4 countries in sub-Saharan Africa. And it's a package of procedures and that was trialed in 80 hospitals. That was 78 hospitals, 2 had to drop out. And so the package involves E, so early detection, using calibrated drapes, and the trigger for the intervention of management of PPH was 300 mLs of blood loss. So that was a big feature of the trial, is early detection and a trigger for intervention being 300 mLs. Then there was a routine massaging the uterus after once the PPH was detected for 1 minute, initiating oxytocin IV, plus or minus misoprostol, and initiating tranexamic acid. The outcomes were, sorry, this is sort of the key interventions. Maybe I'll go back to, actually I'll show you the calibrated drape, sorry. So this is a sort of calibrated drape that's available, and it's fairly low cost. There is a reusable tray, because I know in Rwanda plastic is not actually used that often, and I'm kind of like that. There is another model of a calibrated tray that's available through South Africa, and the overall cost of the emotive bundle was felt to be quite reasonable. And then the cost of the calibrated tray versus the draping. If you use the tray, it's actually 8 cents per birth over 5 years, whereas the drapes are about $2. Okay, I think that's what I wanted to say about the emotive trial. Is the other very interesting part of the emotive trial was that they had a series of simulation, monthly audits, mentorship, and a real system of trying to improve skills amongst the birth providers. And so I think that's a big part of the success of that trial, which showed 60% reduction in bleeding and death. So there was a significant reduction in the death rate. Now, this is the JADA system, which is a single-use, high-cost sort of vacuum system for a uterine atony that I won't go into that much. This is something that's being used in Canada and BC. It's a 24/7 mentorship program for obstetrical care. Okay, so then I think this is the summary end point, is these are carbetocin, ergometrine plus oxytocin, although that's not available here, misoprostol plus oxytocin, was shown to be probably a bit better than oxytocin on its own. Now, when Dr. Relisa was saying that the oxytocin may be a variable quality, one considers that maybe carbetocin is a better option because you can buy it directly from that company through IDA, and it is heat stable and it has appropriate quality. So I'm just wondering if that's an option for active management of third stage of labor. And then in terms of the summary for PPH management, I think there's so much to learn from that emotive trial. It was a large trial of over 200,000 women, and really their big sort of conclusion was time is of the essence, early detection through calibration of blood loss, and the medications to be given as soon as you detect and diagnose PPH with the oxytocic drugs and tranexamic acid. And then I'll say again, the addition of mentorship, simulation, monthly audits, and quality improvement for PPH was all part of the bundle that was used to reduce the rate of death. So I think all of that could be considered for Rwanda. So I'll leave it at that.
Thank you. I'm sorry for my timekeeping. So I'm actually going to request Dr. Patel to be on the stage and Dr. Grace Chen to be on the stage. And we're going to have our last, as you can tell, this panel or this session is all talking about PPH, learning, surgical skills, all that. So we're going to have another person. If you've gone out there, you might have done a stitch. If you haven't done a stitch, please don't leave this room without going outside there and do one stitch, either a billinge or the uterine arterial ligation or anything else. They can help us. So let's put our hands together to welcome Dr. Chen to come and talk to us about stitch.
Midway. Okay, thank you so much. Yes. Okay, so while we're waiting for my slides to come up, it's truly a privilege and honor to be here with you and to share this new innovation that we have in PPH surgical simulation. And I want to thank the RSOG Planning Committee for brilliantly combining the three of our talks in sequence. I'm hoping to round off this theme by talking about both PPH and simulation and how they might be married. But I realize that in addition to this privilege, I also have the challenge of being the second to last thing that's keeping you from lunch. So I'm hoping to rouse you from your hypoglycemia with some videos later. So I will prompt you to nudge your neighbor when those videos come up, because those are not to be missed. All right? Oops. Now, in terms of disclosures, mine is that, as Professor Fawzi told us this morning, everything starts with a thought. And all of this started with a thought. This idea for the simulator was in my brain for about 3 years, and it took that time to find an appropriate team, and you'll learn more about the journey to find a team to create this so that we could put it in the hands of healthcare providers. And so I am the president and co-founder of Stitch, which you will meet shortly, but I don't actually currently receive any funding nor revenue. So this is the outline of what we're going to talk about in our time together. So we'll quickly review the burden of PPH, which I think this room is quite familiar with. We'll see how it aligns with the sort of higher level strategic priorities. Then we'll talk about the gap, the solution, which we feel is Stitch, the procedures that it's capable of, and then I'm going to show you some data behind the model, and then we'll talk about where we hope this is going or the future. So in terms of the burden, so I think everyone in this room knows PPH is the leading cause of maternal deaths worldwide. So we're talking about 14 million women who experience PPH every single year, 70,000 deaths that occur from PPH every single year, which means that every day 200 women die from PPH around the world, or in other words, 1 woman dies every 8 minutes. So I think even as OB-GYNs and GPs, nurse midwives, sometimes these numbers can become a little bit academic, shall we say. So to put this into perspective, by the time my presentation is over, 4 women will have died. Now, we know from this WHO document, more than 80% of these PPH-related deaths in the world occur in sub-Saharan Africa and South Asia. And furthermore, from this fact sheet, we see that time and time again, of course, PPH is among the top, if not always the top, cause of maternal death. But let's take a look and see what the more recent contemporary literature tells us about the current state of affairs of PPH. So in Rwanda specifically, I was only able to find 2 studies on PPH in the last few years. The first is from the northern province. Both of these studies mostly look at PPH risk factors and prevalence. So this prospective case control study showed that PPH prevalence was approximately 25%, and not surprisingly, the primary cause was atony. At Rinkwavu in the eastern province, this is from July 2024, another retrospective cross-sectional study showed the prevalence was about 15%. Now, of course, those 2 articles stand on the shoulders of this, which was led by Dr. Rulisa and his team. And I think most of you are quite familiar with this study, which looked at DHS data between 2017 and 2019. Among other things, this study showed, of course, that the top causes of mortality, of maternal mortality, were infection, followed by hemorrhage, followed by hypertensive disorders. Now, beyond this, I actually couldn't find articles that had data past 2020 in Rwanda. But what about the rest of the region, the rest of sub-Saharan Africa? Because when we think about the 70,000 PPH-related deaths every year, presumably, many of those women would have required more advanced surgical intervention, right, to treat that catastrophic PPH that ultimately led to their demise. So with that said, again, I found very sparse data from the region looking at surgical PPH management. In fact, I only found 2 studies overall. The first was somebody's master's thesis from University of Cape Town in 2017, and the second is a study from Cameroon. So very quickly, this master's thesis was a retrospective chart review of 6.5 years worth of data. And essentially, they were looking at the outcomes of patients undergoing uterine compression sutures for severe PPH. And you can see 93% of these were done after C-section, the rest after vaginal delivery. About 63% were done by OB registrars, so for the North Americans in the room, that's an OB resident. And then about 18% by consultants and medical officers. Now, in 93% of cases, these worked. So the sutures successfully stopped PPH, and they avoided the need for hysterectomy, and of course, avoided a maternal death. In the remaining of cases, so 7% or the actual 8 cases, the sutures failed, and those women required hysterectomy, and that resulted in 1 death. So if you do the math, that means that 99.13% of their patients survived, and these sutures saved them. This is the only other study I found. So this is the one from Cameroon, a 2017 retrospective cohort study looking at 10 years worth of data with a sample size of 60. And so they were comparing these uterine preserving surgeries, which we'll see a list of in a second, versus hysterectomy in treating severe PPH in 2 tertiary care centers. Now, the primary reasons for their surgeries were, not surprisingly, uterine rupture and uterine atony. This was the distribution of the cases. So 40% of those patients underwent uterine preserving surgeries listed there, and then 60% underwent hysterectomy, disaggregated further into subtotal versus total. Now, their uterine salvage rates were very interesting, because if you look here, their bilateral ligation of the internal iliacs or the hypogastric arteries had a success rate of 86%, or a uterine salvage rate of 86%, which is actually much higher than that has been shown in other studies, which is normally around 69–70%. And those studies are cited for you at the bottom. So there's a 2022 review, and then also a 2007 meta-analysis that looks at this. The rest of their success rates were pretty consistent with the literature. Their uterine artery ligation was actually quite low, surprisingly, but the compression sutures, they used B-Lynch, whereas these are mixed sutures, and the triple ligation were, again, consistent, if not better, than the literature. In spite of that, they actually showed that uterine preserving surgery was significantly associated with maternal death. And this was the distribution of the deaths. So 7 deaths in the UPS group and 2 hysterectomy deaths. Now, the authors actually attribute this to a delay in performing UPS. Unfortunately, in 3 families, or 3 patients, it was because of inability to pay. So they delayed mounting the UPS surgery. There was also a lack of a clinical decision-making tool or algorithm. Many of these patients were in severe hypovolemic shock, and then they had significant supply challenges in terms of blood. And so you can see here that there is likely limited external validity, right? They had high rates of uterine rupture. Their mean antenatal care visits were only 2 for that pregnancy. Most of these deaths, as I said, were due to severe hemorrhagic shock. And interestingly, this particular healthcare cater resorted very quickly to internal iliac artery ligation over B-Lynch, which from my work in Canada, various parts, rural, urban, as well as in various countries in sub-Saharan Africa, that's highly unusual. Most OB-GYNs do not resort to internal iliac artery ligation over the more conservative surgery, shall we say. So we can see there's a problem with PPH. And of course, we'd all like to move the needle on those avertable deaths. But how? So we know that intergovernmental organizations have devised these strategic priorities to help address PPH. You're all familiar, I'm sure, with this roadmap document from the WHO, where they put an emphasis on a few things. So the strengthening of training of healthcare workers and providers, hands-on training and simulation, but also they state that there are barriers to implementation and also capacitating the workforce. Moreover, in March 2023, there was the first global summit on PPH in Dubai, and they outlined some key actions to try to eliminate preventable PPH, which include, as you can see, research and development efforts to try to devise innovations to address unmet needs, strengthening global collaboration across industry, innovators, researchers, and then ultimately trying to coordinate capacity building efforts to emphasize knowledge dissemination. So this is all great. Policy documents are excellent, but as a surgeon, I'm a doer. So once we've identified the problem, I'm a big fan of finding a tangible solution to the problem. And certainly as a medical educator, my visceral reflex is to try to find some sort of teaching solution to this. Now, we know from this February 2024 study that was published that there is an immense impact of teaching. This was one of the first studies to actually quantify the impact of a single surgeon. So they showed that one surgeon in his or her lifetime can impact more than 400,000 patients through what they call this multi-generational multiplier effect. So in essence, the surgeon trains the first generation of trainees. Those trainees then go on and train the second generation. And there you have the multiplier effect. Okay, and this was actually a plastic surgery study in a low-income country. But really, I would say the argument would be even higher for that in obstetrics and gynecology, because of course, as we all know, we have significant task shifting. So we're not just training our surgical trainees, but also those other cadres as well. So in terms of the gap in teaching surgical procedures to manage PPH, it's really twofold in my opinion. The first is that of healthcare provider skill and comfort level. So I only found one study on this. I looked at North American literature, sub-Saharan African literature, Asian literature, and there was only one study out of France, which looked at the comfort level of both obstetrician gynecologists, but also the trainees, so residents in France, on performing these surgical procedures to manage PPH. So as we can see from this 2016 study, they surveyed 286 obstetrician gynecologists. 33% felt that they had not mastered uterine artery ligation. 40% felt that they had not mastered triple ligation. So that's uterine artery, round, and uterovarian ligament ligation. 47% felt that they had not mastered peripartum hysterectomy, and 18% felt that they hadn't mastered any of these. I'm not too concerned about that internal iliac artery ligation again. That's a more advanced procedure in a more terrifying part of the pelvis. So, but the rest of the numbers are concerning. The group 3 years later then went to survey French residents. So same jurisdiction. So there were 156 French residents in the 4th and 5th year of their training. So these are the last years of their training. And in France, interestingly, they're legally allowed to practice alone. Okay? If you look, 75% at the end of their training felt that they had not mastered uterine artery ligation, 85% triple ligation, and 78% peripartum hysterectomy. So of course, when we have catastrophic PPH, no matter where you are in the world, the primary concern, of course, is for the patient and the family. But the downstream effect here that we're not really talking about is that there's also the implication of the second victim syndrome. So if you're not familiar with that term, it refers to the psychological trauma that's experienced by healthcare providers after a near miss or a very bad patient outcome. And again, as healthcare providers in the room, I think we're all very good at compartmentalizing and moving on with our day, moving on with the next patient or the next task at hand. But ultimately, this is going to be tied long-term to those issues that Professor Ann Kihara told us about yesterday, right? Motivation, burnout risk, and ultimately retention in clinical practice. So I don't think this is something to ignore. The second gap, aside from healthcare provider skill and comfort level, is that currently there's actually no decent, quality, accessible simulator or model to practice these surgical procedures for PPH. There are basically two extremes right now. There's the low-cost, low-fidelity, homemade using like textiles, plastic wrap, what have you. And usually those are limited to procedures like B-Lynch and subtotal hysterectomy or subtotal hysterectomy, but usually not all three. On the other extreme are the high-cost, high-fidelity. They even give you fake blood, but at an astronomical cost of $10,000 to $15,000 US. So I will say that as a Canadian-trained obstetrician gynecologist and the other two Canadian OB-GYNs in the room, none of us have ever used or even seen one of these models because our programs cannot afford that. So obviously those price points make this inaccessible to almost everybody in the world. And so, to address this gap, we devised Stitch, which some of you have seen out there. And that's this here beside me. So this is a portable, reusable, low-cost, intermediate fidelity simulator. And it was namely designed for these three procedures. So PPH surgical procedures consisting of compression sutures like B-Lynch, Cho, Heyman, Pereira, uterine artery ligation or triple artery ligation, and finally subtotal hysterectomy. Now, I've been told by our global partners and end users that it can also be used for, let's say, repair of the hysterotomy, to practice that, practicing repair of uterine extensions. And some of our Tanzanian partners are intending on using this to practice bladder dissection. So basically they would use the special glue we provide and create bladder adhesions and then train their participants in how to dissect the bladder off safely. And there is a potential space to put in a bladder. Now the base ureters that are inside, as well as the skin, are reusable indefinitely. The base is based on an MRI of a female pelvis. So for the surgeons in the room, and for those of you that have tried it, it truly simulates the breadth and depth and tight space of working in the pelvis, which again, it's not just about having the organs in front of you or having a stuffed uterus in front of you, it's simulating that whole surgical experience and having to navigate and visualize the important structures. What you see there is the uterus, but there's also adnexa, infundibulopelvic ligament, uterine arteries, ureters, all the other ligaments you would take down during a hysterectomy. And so the uterus can withstand about 20 to 25 rounds of the compression sutures and uterine artery ligation, after which you'd likely have to do the hysterectomy, and then you can easily replace it with another uterus adnexa combo. Now this is the team behind Stitch. So I did not do this alone. And as most of you who are surgeons can imagine, an OB-GYN cannot design this alone. It really requires the harnessing of both the evidence-based science behind simulation, but also the synergies of biomedical engineering with OB-GYN expertise. So this group here, there are 5 Canadian Masters of Biomedical Engineering professionals who actually have a very diverse and complementary skill set that enabled us to design Stitch. They have various subspecialties just like we do. And of course, the aim here is to scale up surgical capacity in these life-saving surgeries to treat PPH around the world in a variety of rural and urban settings. Now, you might be interested to know, well before I met this team, I'd actually pitched this to engineers in Kigali. So my intention was always to have this manufactured in the region, and we have some UGHE students and alumni here in the room, because of my work at UGHE, I was able to connect with the SimLab folks who then connected me with engineers in Kigali. And so they said to me after the pitch, brilliant idea, we love it, but we work in orthopedics, so sorry, no alignment. Nevertheless, when we were talking to them, we intentionally consulted them to select materials that are readily available here, again with the intention that long-term it would be manufactured here. And you'll see at the conclusion as well why. All right, this is the time to nudge your neighbor if they're scrolling their phone or napping. You don't want to miss these videos. Okay, so we've designed 3 step-by-step surgical tutorial videos to accompany Stitch, really as an educational tool, but also as a supplement so that people can review them on demand to continue the learning process. So these are not the surgical tutorials because in the interest of time, I can't show you the full ones, but these are the sped up ones, okay? So this is obviously B-Lynch compression or suture. You will see that there's actually no hysterotomy made. You could. The classic teaching for B-Lynch, when Dr. Christopher B-Lynch wrote it up in 1997, was that you would have an open hysterotomy, but new literature says that you don't need the hysterotomy, and it would make sense, especially if this is after a vaginal delivery or you've already closed the hysterotomy at C-section. You don't have to reopen per se. So again, these are sped up. The next procedure, as I had mentioned, is uterine artery ligation. And of course, this skill can be used not only in the setting of PPH, but we also will use it, say, in a gynae hysterectomy where you anticipate a lot of bleeding. So let's say for those with myoma or fibroids. And then also if you have a planned cesarean hysterectomy, right? These are skills that you might use to, like say in a placenta accreta setting, to decrease your overall blood loss in the surgery. And then finally, this is a subtotal hysterectomy, again, very sped up, that I did with one of my OB-GYN colleagues. You'll see that we did not take the round ligaments separately. Again, we were trying to emulate that very fast emergency peripartum hysterectomy where you've tried other things and now you just have to get source control. So we took the round with the uterovarian ligaments and so forth. And actually, my colleague, Dr. David, and I have been planning to do a hysterectomy today, but unfortunately, it was scheduled for the coffee break. So we're going to try to squeeze it in before the General Assembly. So if you're interested, please come and watch. And here we go, amputating the cervix. And then you'll see we oversew the cervix. So of course there are variations on this procedure. This is the way that we typically do it. But the point is that Stitch allows you to do those variations, right? However you prefer to do your subtotal hysterectomies. All right. So very quickly, I'd like to show you the data. So thus far, Stitch has actually been tested by an array of interdisciplinary healthcare professionals hailing from rural and urban Ethiopia, Rwanda, and Canada. And the data supports that Stitch is an anatomically accurate, portable, as you can see, accessible simulator with excellent fidelity. So this was the group that we asked for feedback. You can see that the majority of them are either OB-GYN trainees or OB-GYNs themselves. So if you take all the trainees with the OB-GYNs, we're talking more than 50% of the respondents. And then, not surprisingly, as with most places in the world, 3/4 of people were in urban settings, about 1/4 were in rural settings. So in terms of overall impression, so these are the impressions on it being a good educational tool to practice, learn, teach compression sutures. So 92.85% of people felt it was 8 or higher out of 10. For uterine artery ligation, 85.36% of people felt that it was 8 or higher. And for subtotal hysterectomy, about 77%. Now, the next slide is very busy, but I wanted to stay true to the voices of people providing their comments. So this is the qualitative feedback that's generally provided here. And so you can see, overall, people really liked the realistic anatomy. They really liked the feel, the needle insertion. And then on the constructive side, there was one person who didn't like the friction, but again, you can come and decide for yourself later. And some of these we might be able to address in terms of making an open cervix for a uterine balloon tamponade, but some of the other things like making the ligaments reattachable, just from an engineering standpoint, is not feasible. In terms of anatomic accuracy, 88% of people rated it at 8 or 10 out of 8 or higher out of 10. And again, you can see the qualitative feedback. Again, overwhelmingly positive. Vast majority really liked the anatomic accuracy. One person didn't like the spongy feel, which is supposed to mimic the boggy postpartum uterus. And I'm not fully confident what the latter comment is on under constructive. For fidelity, so this is essentially talking about how closely it resembles in vivo organs and tissues. 71.43% rated it at 8 or higher. And again, for the qualitative feedback, you can see the majority really liked the feel of the tissue. So not just the uterus, but the ligaments, ovaries, et cetera. Again, you can see a few people who were naysayers, but most people felt that the fidelity was quite excellent. And then in terms of portability, you can see there's more consensus here. So almost 93% felt that it was quite easy to bring between facilities, to a different region, et cetera. You can see here that it's quite small, and so you can actually put this into a carry-on suitcase to, again, bring it between places, and it's quite light as well. Under 5 pounds for sure, but I haven't weighed it to provide you with a strict measurement. Again, in terms of portability, overwhelmingly positive feedback. And then finally, in terms of ease of assembly, so this is made to be quite quick to assemble, so 92% or more of people felt that this was 8 or higher. And no constructive feedback. Most people feel it's pretty easy. All right, and just to end off then, I had alluded to this earlier, but Stitch is currently in many parts of the region. So Stitch is right now in DRC, in South Sudan, and Tanzania. And we've entered procurement conversations with partners in Ghana, in Chad, and in Angola, as well as in various parts of rural and urban Canada. And we're about to enter validation studies across many of these different settings and end users and healthcare provider cadres. But as I had mentioned to you, the intention from the start was always to have Stitch manufactured locally for end users in sub-Saharan Africa, hence why I pitched it to those orthopedic engineers in Kigali. And so, of course, that didn't work out initially, so I just wanted to find the most efficient way to make the model and get it into the hands of people that need it. But the plan moving forward, as I've mentioned to many of you who have stopped by the booth, is to shift manufacturing to sub-Saharan Africa, ideally Rwanda. And of course, this will support local industry, this will improve sustainability, but it'll also reduce the carbon footprint overall. And so because of this, we've created a decent business case to make this a viable venture for somebody to then take this on. And so we're currently looking for the right partner to move forward with this. So if any of you have engineering friends, please come and let me know because I'd love to make those connections. So I'll end it there. That's all I have prepared for you. Murakoze chani.
Here's the thing. Amazing presentation. And the stomach is probably claiming. So what we're going to do, I'm going to request everybody to stand up. Let's do it. Let's stand up for a second. Stretch, 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 stretch a little bit. Stretch, 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 stretch. You may be seated. So we're going to discuss and agree. We're going to open the floor for questions because I believe you have lots of questions for these amazing speakers. Then after that, I'll come back with the next, and then we have lunch after that. But we'll have 2 more things to do, then we are done with the day. So let's get the questions. One hand. Can we see if we have another hand so that we know who's actually going to ask questions? Okay, go ahead. Keep it short.
Yes, thank you very much. For bilange technique, what can you give us as a strategy to monitor if really what you are doing is fine, the patient is not in danger? You are operating, you have done the bilange, suturing. How do you monitor very quickly that the technique is correct? You are not going in danger. You are not going to lose the patient. Thank you.
Great. Do you have another hand? Before as you're thinking about it, I have questions for both speakers, Dr. Chen and Grace. How can we scale these two initiatives? Because I think the scalability is needed mainly to the low and middle income countries. Because simulation is the way to go. Believe it or not, if we don't simulate, we don't get to do anything on human beings. So how do we do this? And one for Patel, I know that PPH is a thing in the other countries, in the Western countries, but us, we are really, really, really struggling in the low and middle income countries. Would you put in a word for partnerships? How can partnerships really help out to the number that I saw every minute, 8 people are dying? That's insane. I'm sorry to use that word. But thank you.
Here we go. So for PPH, I think we're hoping that our Canadian work here is useful because we are implementing a train the trainer program, and part of that program is simulation for PPH. And we have been going out into the health centers to follow up whether the training program has been useful. And I think maybe it has. Like I heard personally from one of the midwives that she had used misoprostol as her second-line agent at one point, and she feels she averted a PPH and definitely a referral to the district hospital. So I think that partnership is great because we have resources. We've gone through this in the Western sort of countries, and so we have educational resources to share, and you should take advantage of them.
Okay, thank you for the great questions. I'll start with the first one in terms of how do we know that during B-Lynch we're not endangering the patient. So I think, again, this really is just corroborating the need for simulation. So as Dr. Chen very eloquently pointed out, right, having a closed loop pathway in doing your simulation, evaluating your student or trainee, moving to the patient, going back to the simulation lab. So I think that's really where the benefit of having a intermediate fidelity simulator is, where you can mimic all of those struggles of being not just it's okay? No. Okay, not just the anatomy, but just the entire experience of working in that process. But also I would say of the 3 procedures that we normally would mount for PPH, my clinical opinion is that B-Lynch is the least risky of those in terms of damage to surrounding structures and organs, and even the speed with which you need to do it and the technical ability. I think it's really the simplest of the 3. And there's a lot of data looking at, should you do B-Lynch first? Should you do uterine artery ligation first? What order, what combination? So there are algorithms out there for that. And then to the second question about scaling and really trying to amplify these models. So we think this really depends on the manufacturing pathway that's available. And so hence the need to, again, make this a collaborative partnership with our engineering colleagues. We can't extrapolate that our competence in clinical medicine and surgery then extends to engineering. So I do think that that requires, as you've seen, authentic partnership with engineers to then weigh in to tell us what is scalable for this particular context and for these particular end users. And very quickly, I'll just make a note that even at UGHE, when I showed it to the simulation lab folks, they already gave me some really interesting, innovative ideas on how to make some modifications that are more appropriate for manufacturing in this setting. So again, I think that just speaks to the wealth of knowledge that's out there outside of the clinical space.
So as you know, I'm a urogynecologist, and I no longer practice C-sections. But if I could address your question, sir, I don't practice C-sections. However, Dr. Louisa, as well as Dr. Diomi, are some of my partners in a project we're hoping to start on safe C-sections. And I will tell you that in my experience, if you're not sure whether or not the B-Lynch is working, obviously in the abdomen, you can palpate the uterus to see if it's hard, but also look under the drape, look between the legs, right? If she's still having heavy bleeding, then you may have to go to some other strategy as well. You know, I think oftentimes when we're doing C-sections, we forget to also look between the legs, look under the drapes. As far as the simulation and how to increase the adaptability, you know, collaboration, it's like transmitting chlamydia, right? And I so completely agree, you need to collaborate and collaborate widely. But I would also say that don't reinvent the wheel. There's a lot already out there. So I would use your resources and maximize your resources. And you know, I think what we saw with the stitch simulation model is great, but there's also a lot of homemade ones that you can really utilize your medical student resources, your resident and trainee resources to make these homemade simulators. You know, I think that's really the key, is you need to be creative, especially when the time and the resources are limited.
I hope that I'm not holding anyone else to speak, which brings me to the end of this amazing panel. Please, let's give them a round of applause. I'm sure you're like, we're sick of you. Get out of there. We need to go to lunch. However, one more thing, please. So we've come to the conclusion of this amazing conference, and you probably would be wondering, what did we do for the last 3 days? So I'd like to welcome Dr. Basonga to take us through some of the key aspects of this conference. It might be a short summary, but I'm telling you, there's a huge list of things that we actually achieved through this conference.
Well, good afternoon, everyone. Oh, you can't even talk. Well, so the conference has been a bit long way, but with a lot of amazing presentations, a lot of science, a lot of policy revisions, a lot of key messages and take home. So as you all know, it started with the pre-conference workshops where we had 2 parallel sessions of emergency obstetrics. As you know, it has been one of the, it has been and is among the leading causes of maternal mortality and morbidity. And it's our primary role as gynecologists to fight or to make sure that there is a decline of maternal mortality and morbidity. So we had sessions, and of course, embracing science and technology. We also had a session on minimally invasive surgery. We did a simulation on hysteroscopy. It was attended by 12 people, due to limitations of resources. So the evening was very fruitful, where we had opening remarks by different partners, as you can see them listed above. You all remember the different remarks from our partners: USAID, World Health Organization, country representative, UNFPA, and FIGO president, who also made a number of highlights. So their speeches were preceded by the opening remarks of our president, Dr. Mevumbi Victor. So we had emphasis of those partners telling us about the importance of the theme of our conference, that it resonated well with the mandates of UNFPA. WHO told us how they are supporting our societies, all professional societies, ours inclusive, and being the core one, to accelerate maternal mortality and morbidity decline. And the most important thing being enhancing health workforce, the 4x4 strategy. So the FIGO president highlighted about the quality. What are the measures to take? How careful should we be as in ensuring the numbers that should be in line with quality? Quality should not be left behind as we embark on universal health coverage. She highlighted about retention strategies, policies, welfare of providers, train them, but make sure they are anchored in the public sector rather than private practice. Yeah, so they also emphasized about mentorship. USAID Mission Director talked about the partnership of our society to mentor the juniors. The FIGO president came back to mentorship as one of the quality measures. So next day, we had opening remarks from the chair of the scientific committee, Dr. Manuel. He started by recognizing different dignitaries present in the conference and re-emphasized the conference theme and rationale behind the global gap, Rwanda inclusive, of the competent, motivated healthcare professional obstetricians, gynecologists. We had that 18 million deficit of healthcare workers by 2030 according to WHO to achieve universal health coverage. So that gap, especially in the rural areas, so it was in this regard that the Minister of Health and RSOG and partners embarked on empowering health workforce to drive progress in women's health. He extended thanks to high-ranking officials present in the room, which included FIGO, RBC, Director General, and others. So again, FIGO president started by recognizing high-level academicians and learners in the room, the residents. So she again came back to data use for informed priority decisions. She showed us an example of data modeling where she looked at HRH in 2012 up to the recent when we restarted 4x4 strategy. She was giving us a key take-home message of making sure that the people we train, we consider quality, welfare of the doctors and other healthcare professionals trained. So she also highlighted some of the barriers to achieve the universal health coverage, despite quadrupling the healthcare workers from the 4x4 strategy. These mentioned were retention strategy, how they remain anchored in public hospitals. She talked about the creche for nursing gynecologists, emphasized on health financing as one of the key areas. She also reminded us about the health insurance policy as barriers. So she also urged us to embrace technology and advancements. Not to forget supplies, maternal life-saving commodities, policies, accreditation, and also talked about retirement, that we should be brave to retire on time as one of the quality measures. So you remember? So the speech was followed by a panel which was enriched. It included doctors, menelers, and high-level academicians from University of Rwanda, University of Global Health Equity. So Menelaus highlighted the journey of Rwanda, that Rwanda has gone through since 1994. He emphasized the political will to drive health workforce to improve quality of women's health in Rwanda in general. And the Dean of School of Medicine and Pharmacy also told us about the 4x4, quadrupling the undergraduate number from previously 100 per intake to 400 now. This is not only in medical school, but also in nursing and midwifery school. The president of Rwanda Society of Obstetricians and Gynecologists also talked about the societal role in the reduction of maternal mortality and morbidity in partnership with UR and MOH. The 4x4, you know, we are among the implementers. We also had a lady on the panel, Luange, who highlighted about involvement of the community in achieving quality health care and universal health coverage. So the panel was followed by a state-of-art lecture about the rheumatic heart disease burden from Dr. Nhirushwa, followed by high-impact interventions to accelerate maternal mortality and morbidity decline by Professor Risa. And these were followed by various scientific oral abstracts. Among them were the CIN lesion clearance in Rwanda from Professor Dawit, you remember? So, today you were here on day 3. We also had, to take you through the panel about cancer that we included different partners in health. You remember the strategies they told us about, from the community level to the screening up to high level cares of radiotherapy and histopathology and other management measures. So, not to forget all members on the panel who included the lecturer. Most of us were present here, so you remember, this is just a snapshot. So today, everyone was in the room. You remember the panel that started talking about assisted reproductive therapy. We have had 2 presenters about that. We also saw the role of laparoscopy in the diagnosis and management of infertility, especially the tubal factors. We also heard from reproductive endocrinologist about what our center in Rwanda Military Hospital is doing, an amazing job. You've heard that the statistics have gone high. The success rate is 55%. So most people in the audience requested that embryo transfer should not be multiple, but one fetus for success, myself inclusive, because we had that burden from prematurity despite the investment. So this was followed by various oral abstracts that you've attended. So I think basically I tried to highlight what the conference took us through. For more details, all the conferences are available on the YouTube. We can share the links, and we want your feedback from the QR codes on your tables. Thank you those who have completed the feedback. And I think we can call it a day, or I call upon the President to give the closing remarks. Thank you.
So, again, it's an honor to me to be in front of you today. to close this important conference. Ladies and gentlemen, it's an honor to me to ready to close this very nice session. So we had opportunity to discuss different topics and innovation, research, best practices, and it's an opportunity for us really to learn and then also to go to implement what we have learned here. Because the main purpose of this conference was to discuss how empowering health workforce in order to drive the progress of women's health. This means a lot because we know we still have issues to really to reduce maternal mortality, preventable of course. So that's why as experts, obstetrician gynecologists, midwives, researchers, academicians, we were here to figure out how we can reach our purpose of saving women. Before I conclude this conference, I would like first to recognize different categories of people, especially speakers, moderators, and also people who were involved in this organization of this committee. But again, much for our member, the RSOG member who were here to support this journal, this conference. Being here, it's not only the thing I want to thank them. The fact that we are together in even preparation of this conference along the way, because to be able to be here right now today, it means there was a wrong journal we had. And as you have seen, this is the 10th annual conference. So we do have this a gathering annually, which means our society really is doing a good job. I'm already proud of you. That's why I have to say it today. And we have one more thing we want to share with you, so that's why I know it has been a very long day today, but bear with us because there is something very important we even prepare before to come here, which we think it's also important to share with you. That's why I would like to call my colleague, Dr. Porphyre. It's a kind of one of the important activity and also priority for the country. Working with youth, ensure that youth are getting information in terms of, in regard to sexual education. So what can we do to help them in order to have those information? So the RSOG is the organization with a mission to lead these sexual reproductive health activities in the country. We have organized a kind of reproductive education quiz. We have identified, we shared reading material with young generation, young people under 20 years, and then come up with we selected the people who, youth who had high marks, and then we want to recognize them here. This is a kind of pilot we did, but with intention to continue and then expand across the entire country, focusing on students in a district, but also nationally. So today we want to share with you that pilot and also to recognize the parent and also the young people who were involved in this program. So, Porphyre, are you ready? Yeah, I think they can come over and then recognize. Yeah, I think probably is not yet ready, but the other point I want to recognize is the organizing committee. We have an organizing committee composed with the member, but also with our staff who are based in our office. So please stand up, and then everyone can see you, and then thank you because you did really a good job during this period, and they combine with the responsibility you do have on daily basis. One more time for secondly, of course, the executive committee. Our executive committee is really amazing because everything which has been decided it's because of the team we have as the executive. So I would like also to request them to stand up and then being also recognized with the audience. Again, I also have to thank some of the speakers and the moderator who came very far. You have seen, we have a various audience here. We have a team, we work together from Canada. We do have a project together. I think this has been 4 years. They usually come here to support the provision of knowledge for our healthcare providers, focusing on emergencies in obstetric and neonatal care. This means they want us really to prevent and manage and protect our population, basically women. So I would like to also request them to stand up and then people can recognize them because we do appreciate this collaboration. And then for your information, we want also to extend this collaboration. So I had the opportunity to also attend the conference, I think this year in June. So I learned a lot from them. So please stand up and then we can also recognize you. And we have another team, I don't know if they're still here, our neighbors who also have been participated in this conference from DRC. Collègues qui venaient du Congo, vous êtes toujours là? Rêvez-vous, comme ça on va vous donner aussi. Voilà. Ils sont venus du Congo pour participer dans cette conférence et merci beaucoup d'être avec nous. You have seen also my mentor, Dr. Grace. She's based in Baltimore, US, Johns Hopkins. So I asked her already to be here to be able to, you have seen what she shared with us because it is aligned with our program. You know, we have a program, residence program in a level 2 teaching hospital. So she's really ready to help us in terms of teaching, mentoring, but also avail some of the equipment which could help in the teaching to make sure that our students, the residents, they have already the quality training, so able to serve and then provide quality service in Rwanda. So I would like also to recognize her. Please, Grace Chan. Being here also, other people were already involved and then they have provided a big support. It's what you can see there in the outside, those are exhibitors. We usually work with them in different things because we do have on monthly basis the continuous medical education. They are there to support us. So that's why you can see them. I would like to recognize exhibitors, a pharmaceutical company, and also others. So we will not get time to call them for here, but we do value what you do for us, and we believe we will continue to work together because we need each other, and then together we can support each other for reaching our goal. So without taking too much time, let me call Dr. Porfi to bring us just shortly a few minutes, and then I can close later. Thank you so much.
Thank you so much. This is a great opportunity to be in front of this beautiful audience. My name is Polyphil. I saw so many accelerators of the progress and so many strengths that will take down all the causes of maternal morbidities and mortalities in Rwanda. So alongside the Rwanda Society of OBGYN conference, we also had a reproductive health educational quiz challenge that was initiated during this summer, and it was a summer challenge for high school students. It ran some few weeks ago, and the top 5 were called to participate in this conference and take their final challenge, after which they're going to be awarded. Please give a round of applause to our finalists. If anyone would want to take the same quiz, they will scan the QR code, but after you're gone. So I would like to announce our winners. They took this quiz during the time they were here in this audience. And I would like to invite their parents, because they are students who are at school. We were able to have their parents, they allowed to accompany the students, and some are representative from their schools. The parents, if they are still here with us, please, you can come in front and join the students. And alongside this, I'd like to announce the scores the technical team can project to a better utilization of time. You can project the scores. And I would like to ask our president to invite those who will be giving the prizes.
Thank you, Porfi. I would like to call the executive committee to come over, and then they can provide this award to our winners. Dr. George Kenneth Runyanj. Valence, are you around? Professor Ngoga, is he around? And the Professor Orisa, he was our senior. Please come over as well.
All right, so there were 20 questions plus one question that was expected to be used in case students have equal scores. So I don't know, from the technical team, is there any way you can magnify the names? So I don't know if you will say that it's unfortunate that many had equal scores, or it's fortunate that our students had very good knowledge on comprehensive sexuality education. And our top two winners were Nhwari Shimwa and Umuhire Sonia. Nhwari, you can stand up and greet the audience, and Sonia. And during the evaluation, we realized Sonia used shorter time to respond to the questions. So that would be an identifier, and we would like to invite Sonia, please. You can come and get your award, and if your parent is here also, can accompany you. And the award is a beautiful laptop that's going to help you through your school. Sonia is a student from Lycée Notre-Dame de Citeaux, just here in front. And our second winner is going to be Nhwari. Nhwari with the parents. Yes, Nhwari, please. And thank you so much to the parents for accompanying the students. We know you took your time to guide the students through the questions and help them how to respond with the correct information. And to tell that these questions were based on the National Curriculum for Comprehensive Sexuality Education developed by the Ministry of Education. Sorry. So our third winner was Iriza. Iriza, congratulations. Mwari is a student from Petit Seminaire Ndera. Mwari nibyo? From Petit Seminaire Ndera. Mwari got one of the most powerful iPads, Samsung tablets on the market, and Iriza as well. Congratulations. Our fourth winner is Iget Ineza, who is coming from Nyamasheke district, together with the parents. Congratulations. Coming from Groupe Scolaire Marie Goretti. So thank you so much. I'd like to now call the team to come in front of this big billboard to have one of our photo for billboard. So the fifth was unable to make it here, perhaps due to unknown challenges. Well, she was expected to be with us, but we did not get her on time. So these are our winners. Thank you so much. Please join. Yes, please join to have a photo on this big board. Yeah, you can stand in between them. You can stand between them.
I'm sure lunch is late, but we can smile. All right, thank you. A big round of applause.
I think we call it a day, and then I close officially this session. Thank you, everyone. So, and wish you safe travel back home. Thank you. Yeah, of course, for a member, we have a general assembly. And if you're after lunch, we're going to meet here, general assembly, then after cocktail.
Housekeeping, lunch is in the same restaurant. Please take your lunch coupon. If you don't have your lunch coupon, see Angelique from RSOG.
Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda. Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries and GMP approvals in over 50, Mega is a leader. Welcome to Mega Life Sciences, established in 1980 and a public company since 2013. With a global presence in over 33 developing countries and GMP approvals in over 50, Mega is a leader in the health industry. Mega Life Sciences has proudly served the people of Rwanda for over 9 years, supporting health and wellness in the region. Our manufacturing plants span across the globe, ensuring the highest quality products for all. At Mega, we believe in helping people stay healthy as long as they live. We are passionate about women's health and focus on developing brands with the modern woman in mind. During pregnancy, nutrition is key, but diet alone may not be enough. That's where Mega Prenatal comes in. Small, easy-to-swallow capsules packed with essential micronutrients for a healthy pregnancy. Ferritone offers a breakthrough liquid in a capsule formulation, eliminating metallic taste and GI irritation for easy, assured iron absorption. Calcivita's small, vanilla-flavored capsules ensure optimal calcium absorption without digestive discomfort. For fast relief from pain, Gofen's unique clear cap technology delivers results in just 15 minutes with minimal GI irritation. Mega's portfolio includes a NAT 400, the purest form of natural vitamin E, Zeman for enhanced testosterone support, and a NAT cream for flawless skin with reduced stretch marks. With a wide range of innovative products, Mega Life Sciences is committed to your health and wellness, wherever you are.
Mega, we care.
Good afternoon once more. My name is Mary Goretti from Mindray Medical. Mindray is a partner to Rafif Medical Company. Rafif is our local partner in the medical equipment company. And today I'm only going to present relevant applications that are used by the obstetricians, gynecologists. So I'm going to concentrate on Mindray's advanced and intelligent solutions for women's health. Okay. At Mindray, we have all the solutions that you can use in obstetric and gynecological imaging, including black and white system for point of care, portable, cart-based from entry level to premium level. We also have tablets, and lately we have handheld equipment. So all these are available depending on your pocket. In addition to that, we also have all the probes that you can use in obstetric and gynecology, including intraoperative probes. Sorry, my pointer is not working. Next. Okay. We have different segments in obstetric gynecology, and I'll start with the gynecological and IVF solutions. And here we have routine 3D gynecology examination, and we've advanced in this. We've introduced 3D uterine solution where we detect uterine anomalies, including biconioid, septate, arcuate, the shapes of the uterus. And actually, it has become more accurate than the HSG. I know still 80% of doctors send patients for HSG, but I can tell you for sure ultrasound has become more accurate than HSG in diagnosing uterine anomaly. I can give you a recent scenario where a patient was sent. This patient had infertility, primary infertility, was sent for HSG. And in HSG, they diagnosed unicornuate uterus. But fortunately, the particular doctor had Mindray 3D endocavitary probe. So with this one, she was able to do the scan and actually diagnosed a complete septate uterus and not a unicornuate uterus, as HSG had revealed. We can also detect the type of cyst in the ovary. So all you need to do, using 3D endocavitary probe, you do TVS, get the routine 2D sagittal plane. The box will place itself. It will detect that you're actually on the uterus. It will place itself on the uterus, click on update, and it acquires the image for you. Then after that, we just do reconstruction, even after the patient leaves. Please, next. Next. Okay, this is an example of arcuate uterus, also recently acquired by one of my clients. As you can see, at times it is difficult to diagnose such tiny details on HSG or other investigations. Next, please. Okay. At Mindray, we also have elastography. And in elastography, we have both strain elastography and shear wave elastography. Now, the shear wave elastography is still under research. But even with that, we are now able to diagnose preclinical stage of cervical cancer. Next, please. Okay, in addition to that, we also have contrast imaging. Now, contrast imaging in ultrasound is used on all body parts. All body parts, but today I'm concentrating on gynecological examinations. And here again, contrast is injected intravenously, and what we use is microbubble contrast. We have not experienced any reaction to the contrast because it does not have chemicals. All we need to observe is the movement of these microbubbles in and out of the region of interest, and that will tell us whether this is a suspicious lesion or it is benign. Next, please. Okay, next. That's contrast imaging. You observe the movement in and out of the contrast. Now, again we have HSG in ultrasound, what we call HICOSI. So HICOSI is exactly like HSG, but now this is in ultrasound. Then we have smart follicle 2D and 3D. Now, smart follicle 2D is mostly used by fertility specialists when you want to know the number of follicles within the surface and also the sizes of these follicles. So this you can use with a 2D endocavitary probe. While the 3D smart follicle is used in diagnosis of polycystic ovaries. And with this, it also detects and counts even the follicles that you are not able to see on the surface. And it gives length, width, depth, and volume of every follicle. Even if there are 20, it will give every follicle a different color. And next, please. It will give every follicle a different color and size as well. Then we have what we call smart V-trace. Smart volume trace, we can use to trace the endometrium. We can also use to trace the urinary bladder. That is, I know that is outside the gynecological work, but we also use it to trace that. Now, next, please. In addition to that, we have what we call smart ERA. ERA is endometrial receptivity assessment, where ultrasound is able to detect blood flowing into the endometrium. And this is also useful to fertility specialists. Next, please. Now we go to pregnancy. In pregnancy, I know the first that I've displayed is what we like most, automatic measurement of BPD, head circumference, abdominal circumference, and femoral length. All you need to do, get the image in 2D, click on measure, click on auto, machine will automatically detect what you want to measure, and it will measure it accurately. It will actually be more accurate than when you do it manually, but as long as your 2D image is also good. Next, please. In addition to that, and this is now using 3D, 4D trans-abdominal probe, you can do advanced cranial measurements, or rather advanced brain measurements, where you can measure cerebellum, cisterna magna, ventricles, just by one click. All you need to do, get the routine 2D image. Get the routine 2D image. Don't go to next, go back. Get the routine 2D image at the transthalamic plane. Then click on Smart CNS, so you'll be able to see the central nervous system. And the machine will be able to do the measurements and label every part accurately. But as long as your 2D image is accurate. Next, please. Then also we are able to do measurements for intracranial volume within just one click. Again, all you need to do is to get the transthalamic plane and click on Smart ICV, and it does the measurement, getting the brain volume. Next, please. Next. 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 Now, we have even advanced further. I'm about to finish. We have advanced further. The machine is more intelligent now. All you need to do, get the 2D, click on Smart CNS, it will detect that you're on CNS, it does all those positions and measurements automatically. Next. Next.
I think that's okay.
Okay. We also have Smart Fetal Heart. Those who do fetal echo know this. We are able to tell every view of the cardiac in ultrasound, but by just getting one position in the upper abdomen, click on Smart Fetal Heart, it will give you all the other views in one click within 2 seconds.
Thank you. Thank
Next,
you.
please.
That's
Now, many times we forget mothers after delivering them. Give me just 2 minutes. Many times we forget mothers after delivering them, don't we? Do we have urogyners in the house? We don't.
Sorry, the time is over.
All right.
We're not going to cut. Sorry for that. Cut.
Can you give me just 30 seconds? All right. Thank you.
Okay, thank you guys. Thank you for presenting that. So let's proceed, and we'd like to present Professor Ann Kihara, our special guest. Let's give her a round of applause.
Okay. Good afternoon, everybody. I'm standing in between your AGM, but really appreciate this opportunity and really want to start. Put the slides up, please. Really want to start by acknowledging the invite I got from Victor and the executive to come to RSOG Annual Congress. I feel really blessed. This is the 10th one, and I think it's been very, very significant for me because I've even gotten an opportunity to see your VVF program. I was able to go and see the Minimal Invasive Surgical Center of Excellence. And the icing on the cake was going to your office. RSOG, please clap for yourselves. I also have been hosted very well. I can't complain. In fact, I was wishing this workshop could go on for 4 days. Now, why am I standing in between you and your AGM? I think there's very important information I need to relate to you. One, because RSOG is growing. You're in your 10th year. So the question is, so what? What next? What have I said? So what? What next? And really, I felt as the FIGO president and the one running all the member societies globally, I don't want you to make mistakes. I want you to grow and grow exponentially. Without mistakes, with accelerated progress. So as we talk about the 4x4 reform program, you will be at the forefront as the obstetricians and gynecologists, so that you set an example to all the other societies and even beyond. And the first thing I want to speak to is institutional memory. I know you have an advisory team, you have your previous leadership in the House, but please do not let that go. That's rule number one. You must always have the institution and the memory of where you started. And for you to do this, Victor, you need to start writing a book, a historical book. In your RSOG office, I want to see founding president and subsequent presidents. I want to see founding executive and the follow-through. I want to see the advisory team because it's going to change over time and you will forget it. In your RSOG, make it a programmatic first pager. After the national anthem, everybody needs to know the history. It is critically important. This is what you look like to me, RSOG, like a tree that started with a small seed, a small vision of a few of you. Now you have branches and you have fruits. And those fruits will continue to increase. Those of you who are farmers, the first time your tree fruits, it may give you 10. The second, 20. The third, 50. 4x4 reform. But this is what I wanted to give to you. You must remain with very clear leadership and a strategic plan. Your constitution is a constant roadmap, but it must be living. What have I said? It must be living, like this tree. Development of leadership and succession, and moving towards organizational maturity. This is where you are. You have a structure, you have developed a culture, you have infrastructure, you have employed officers, thank you for the 12 people, policy environment, branding, and stable financing. The stable financing, we can do better, but we're getting there. Consistent partnership is what you now need to look for, not an ad hoc for Congress. I want corporates, and the two gentlemen here know, I'm talking to them. Satisfied stakeholders, promote innovation, supportive environment, institutionalized learning and development. So I'm cascading you so that University of Rwanda can start doing e-module, can do continuous professional development with you, and the other institution like MIS, which I visited this morning. That's moving forward and making progress. Governance and compliance with accountability. What have I written there? When the roots are deep, there is no fear of the wind blowing. If there's nothing else that you need to remember, it's that statement. It's an African statement. So sink your roots very deep. And how can we do this? We must begin to think about sustainable financing by diversifying our revenue streams. Cost management, have reserves and investment. And here in investments, I really like talking to you about the fact not all of us are immortal. So an endowment fund, a property fund, or an investment that gives you passive income as RSOG. More importantly, customers and stakeholder engagement. Know your market, retention, and relationships. And I've started with members. How many of us are members? Hello? In RSOG, how many of us are members? How many? I want to be sure you're not sleeping. So, how do we attract more members to be paying members, including private practitioners? I personally feel it should not be an exemption. But what are you doing to attract them? Ministry of Health, and the list goes on and on and on. But I want to focus on the last one, twinning with other member societies. FIGO has a perfect platform. So if you're talking to me and saying, and we want to twin with EBCOG, for example, or I want to twin with the UK, RSOG, I want to twin with RSOG. Or I want to twin closer home to Kenya, Tanzania, Uganda. This is the girl you need to talk to because it's very easy to twin. And with twinning comes a lot of things. Learning, sharing, research agenda, and even social times like this Congress. But you must move to business unusual. Unusual. Business what? Business what, ladies and gentlemen? Unusual. What? Technology and innovation must be put in place. Talent and acquisition and retention. Magnifique is here from the diaspora. Why? He has a talent you want to tap into, and a few others. Then develop employee skills and retention strategies. I'm almost done, so let's pay attention. This is how you are as RSOG. I want you to move from what we call hierarchical dictate to wire dictate. Victor, please pay attention. Wire means what? You've been used to saying that's the president, that's the executive, that's the advisory board, that's the membership. But now as you grow, you must move towards having a network of member societies you can relate with. That's extremely important. Resilience. I won't read through everything, but risk management, crisis management, organizational resilience, branding, and sustainability and social impact for your members and as an organization. Constitution will need to change based on all these things I have discussed. So, this is the most important slide. Way forward with FIGO. Twinning with member societies, South-South collaboration, scientific committees with directorates, publications, webinars, exchange programming and career development, co-creating of grants, and last but not least, increase our voice and agency as a collective in global women's health. And with that, I will say this. Coming together is a beginning. Keeping together is progress. Working together is success. You're on the right track. Please learn. And please take this to heart. Your leadership needs to interrogate these slides if you are to truly succeed for the next decade. Thank you so much, and be blessed.
Thank you. Let's give her another round of applause. I can say I'm learning so much, and I'm sure you guys are too. I'd like to welcome Victor up to the stage as well.
So thank you so much, MC. Yeah, so what can we say with this speech provided by our President Figo? I think it's incredible to have really Professor Beatrice, the President's Figo President. So she was able to attend this 3-day conference. So we learned from her, we had many inspiration from her. You have seen this presentation today. So she went in our office, she visited our office, and then she gave us really good advisor, a plan for many things. This is a summary. This is a summary. So in upcoming days, we're gonna meet all of us and then develop what she gave us as a guidance. So thank you so much. We have planned to give a kind of souvenir, gift. So it's a time, so perfect, please come over.
Thank you so much.
So this is for you, the sign of warrior.
Yeah.
Warrior, and then you're protecting all the women around the world. So
Thank
really
you so
appreciate
much.
it.
I'm jealous. Too bad.
You'll find out later.
Let's get a picture. Thank you. Thank you so much. Thank you. I'm so welcome. Thank you. Thank you. Thank you. God bless you all. Thank you.
So